Good evening, friends. It's indeed a pleasure and honor to start this program on electrophysiologic aspects of VT ablation and different aspects of ventricular arrhythmia. We are really honored to have two outstanding faculty from the US, Dr. Puganendi Vijayaraman and Dr. Henry from University of Minnesota. And we have been having a very good time and interaction with these. I would like to welcome all of you for this, and I think a lot of you are joining virtually. I can see Yash there, and we'll hand over the session to Dr. Yash and Raja and Vivek to start. Raja, you can. Yash, are you able to hear us? I think you're muted. Can you come over to the...
Can you hear me now?
Yes, please. Loud and clear.
Good. So, we start the session.
There's some problem with the translation.
Hello, Narasimhan?
Yes.
Not this. Can you hear me?
Yes, please.
So, do we start the session?
Yes, please.
So I think I think you're going to speak first, as I saw, and you're going to speak on the selection of the patients for ablation in structural heart disease. Am I right?
That's right.
So I think this is Narasimhan, this is a very important topic because, you know, the ablation can be simple and short, getting over in a couple of hours, or can be really long, taking multiple people and really a very experienced team to approach it. Unfortunately, what I have seen is that most groups which do complex EP do not have a very, at least in the private sector, don't have a full-fledged team with them. And therefore, I think depending on the capability of a particular center and their resources and expertise at their availability, should they decide what type of structural heart disease VTs they should get into. And therefore, your talk would be especially relevant for us, and I'm sure for many other parts of the world. So looking forward to hearing from you, Narasimhan.
Thank you very much, Yash. I'll keep it very brief. Vivek, Raja and Dr. Yash. First of all, we'll set the context. Why do we need to consider VT ablation? We have had proven therapies. ICDs are effective to prevent sudden cardiac death. However, they are expensive and shocks are quite painful, and there are multiple problems related to the hardware, and most importantly, at least a subset of patients. This is what you see is the survival in MADIC-2, and this is from sq.ft. After an appropriate shock from a device, the mortality significantly increases, and the survival comes down with recurrent ICD therapies. So whether it's the cause or the effect, we don't know, but we do know the recurrent shocks from the ICD is not pleasant, and there is some indirect evidence to suggest it causes myocardial stunning injury and therefore increases mortality. The hazard ratio is close to 4 for appropriate shocks, and for inappropriate shocks, it's almost twofold elevation in mortality. Now, this is from MADIC-2. Compared to the control population, you can see that even though the sudden cardiac death significantly comes down in the ICD population, you find that their death due to heart failure significantly increases. So, we find that over years, the tools have improved with 3D mapping, contact force, and our understanding of VT circuits have steadily improved, even though it's not perfect. And therefore, the indications have kind of widened. Among patients, the commonest subset is car-related VT in patients with coronary artery disease. And the standard of therapy, at least in India, is we tend to use either sotalol or amiodarone, depending on the patient's ventricular function and toleration. And despite this, if a patient even has one breakthrough episode, we consider catheter ablation as an optimal form of therapy. Surprise, one thing I wanted to mention is patients with coronary artery disease and scar may have multiple morphologies of VT coming from the same scar. And it just needs multiple exits from the anterolateral or inferolateral area to be ablated. And multiple morphology doesn't mean it's a poor outcome. In patients with coronary artery disease and recurrent symptomatic monomorphic VT despite antiarrhythmic therapy, or when antiarrhythmic therapy is contraindicated or poorly tolerated, catheter ablation is recommended. I would again like to pause. Ever since we started doing DLCO among patients on amiodarone, the diffusing capacity is a very, very sensitive marker for amiodarone toxicity. By the time you detect by PFT becoming abnormal, it's too far in the game and it's progressive. So we are able to pick up patients. If you have a very good quality control, DLCO is a very good indicator of an early involvement of the lung, and several of these patients we were able to stop and change over to other drugs or consider ablation at an early stage. Among non-ischemic cardiomyopathy, initially there used to be a reluctance to take these patients. However, with I think the next talk is going to tell us, with pre-procedure imaging, the VT circuits are better defined, and therefore, again in these patients, when you have sustained monomorphic VT who are refractory to medical therapy or medical therapy is ineffective or it's contraindicated, ablation is recommended. And this is also useful both in coronary artery disease and patients with non-ischemic cardiomyopathy when they have a VT storm. Recurrent VT and recurrent shocks from the device increase mortality, and therefore most of the patients in desperate situations, they come back for a curative, not curative, at least for a palliative therapy. Among patients with congenital heart disease, the commonest subset we see is post-tetralogy VT. We have done quite a few, and these are usually around the patch or the outflow, and the circuits are again better defined nowadays, and getting rid of the VT is not very difficult in patients, provided the RV is not very dilated and the PR is not very severe. If the patient has severely dilated RV and severe PR, they need to go for surgery, and there are clear guidelines when to refer for surgery. I'll just start with this patient where this is not an uncommon situation in India. Several of the patients who reach to a tertiary care center, they reach after 24 to 48 hours after an MI, whether it's after thrombolysis or after PCI, and these patients present with delayed reperfusion causes recurrent monomorphic or polymorphic VT after reperfusion in the ischemic territory. Please don't give up on them. This is not a very difficult, at least a reasonable amount of success we have had in the last couple of years. With if you can overdrive pace and stabilize these patients, very often they have triggers around the peri-infarct zones, and the triggers are usually the surviving Purkinje fibers around the peri-infarct zone. So the success rate is quite high. If you can tag all these areas around the low voltage and you have a pre-potential, you can get rid of these by successful catheter ablation. This is one such example. Patient with a very prominent fascicular potential. You can see when there is an ectopy, there is a delay between the Purkinje to the myocardial fiber. That is, there is a delay at the junction of the Purkinje to myocardial connection. And this is a consistent finding we have seen, and targeting these areas, you are able to get rid of the VT and temporize the VT storm in quite a large number of these patients. And this is one such example where you tag all the Purkinje fibers around the infarct zone and take care of those Purkinje triggers. The other increasing success rate, at least in southern part of India, we get patients with Brugada syndrome, where most of the substrate is in the epicardium, and thanks to the work that was done by several groups, both in Europe as well as in the US, we recognize that commonest substrate for this is in the RV epicardium, and you have signature sign of an abnormal potential there, which is suggestive of a mid-myocardial late potential, and you can target these areas for successful ablation. My colleagues Abhijit and Daljit have put together a series of patients. We have now about 6 or 7 patients who have successfully undergone VT storm ablation in Brugada syndrome. Only one has had a recurrence after several years. So I think I'll stop here. We'll have more discussions because they know this patient selection is, as Yash was saying, this is a complex problem, and more often it's a clinical decision making. You don't take patients with terminal heart failure who are about to be transplanted, who need a definitive device. Such patients, you don't take them up for an ablation. Patients with severe PAH, severe right heart failure, PAINSET score is a very useful score for us to decide which are the patients not to take up for ablation, because you are likely to have a very high recurrence and post-procedure morbidity and mortality will be high. Simple questionnaire with, for example, Seattle Heart Failure Questionnaire and PAINSET questionnaire have been validated in this setting for VT ablation. If they are unfavorable, we would suggest not to take up these patients for ablation. I'll stop there and we'll have more discussions towards the end of the. This is another patient which I think Daljit was following up. Recurrent VT to the extent the patient develops multiple shocks, and she developed ischemic hepatitis and thrombocytopenia. You can see the liver enzymes grossly elevated, thrombocytopenia, and after successful ablation, she's doing well for several years after the ablation. So these are difficult problems. As Yash was saying, you need to have a very involved anesthetist with you, intensivist to take care of these patients. The medical issues, ventilation, all these things are extremely important. But however, with thanks to the technology, we are able to offer better results to these patients over the last decade or so. Balbir is also here. We'll have comments from Balbir, Vivek and Raja. Thank you.
Very clear message to many physicians is to refer patients early. So what happens is they exhaust all therapies, they've got multiple shocks, they are in acidosis, and they expect us now to turn the table around. And I'm quite sure that you get the warning signs at least 15 days to 1 month before the patient goes into electrical storm. He starts getting ATPs or non-sustained VTs, he starts feeling unwell, and that's the time to actually get him to the lab. He's more stable, you can do a much better job than to get a patient late. So the message is very clear that early ablation is the key to a great success.
Right. Thank you.
Wonderful talk, sir. Just one small question. So the definition of structural heart disease changed depending on our imaging modalities now. Now we have MRI. So several patients come who have normal echo, but they have a ventricular arrhythmia, and then we subject them to an MRI, and a limited scar is found somewhere. So, I mean, would you like to comment on the success vis-a-vis advanced structural heart disease per se?
It's very, very important. In fact, I think probably Andre can refer to this. There is specific subset called as arrhythmogenic cardiomyopathies now, not specifically related to DSP mutation or LMNA mutation, but increasing recognition. I think we have close to 20 odd filaminopathies. They have very similar malignant cores. And do you have, Andre, can you just put 1 or 2 slides, or I think he has a large database of these patients. So what we think is idiopathic PVCs, when you do imaging and you find microscopic scars, very often the PVCs precede the onset of cardiomyopathy. Phospholamban, for example, typically presents a varying coupling interval of PVCs, and that's a clue that it's not, all is not well. And nevertheless, these patients, if they have an LV dysfunction and there's a high density of PVC, getting rid of them with good success rate may slow down the progression of disease. Again, the threshold for putting an ICD as EF of up to 50%, people refer for an ICD in this subset of patients.
Now we have Dr. Venkat.
Dr. Henry. So Dr. Henry will be speaking on role of imaging before and during VT ablation. So this is a very important area, and a lot of understanding about what you have to do in the lab comes from what you see before it. And you can change a lot of strategies based on what you see by echo, MRI, and maybe ICE in the lab.
Okay. Perfect. Good evening, everyone. My name is Anu Rukos. I'm one of the electrophysiologists at the University of Minnesota. I actually came in 10 years ago to work with Daljit. Back then, Mandar was still a fellow, so I was still a fellow at that time, to see some interesting cases. This is how I know Dr. Narsimhan. So thank you for the invitation to talk today about the role of imaging before and during VT ablation. So regardless of the ablation strategy used, VT ablation relies heavily on complete identification of the arrhythmic substrate. The conventional 3D voltage mapping can be limited by poor catheter contact, by far-field signals, and by difficult anatomical locations that you can't necessarily get to easily. Cardiac imaging with ICE, CT, and CMR, they play a very, very important role in defining the arrhythmogenic substrate, defining the best access, and defining the best targeting approach for VT ablation. I'm going to focus mostly on three main modalities, as I have mentioned: cardiac MRI, cardiac CT, and endocardiac echocardiogram. I'm going to talk a little bit more about cardiac MRI, since there is a lot of increased interest in cardiac MRI as a modality to define the cardiomyopathy and target VTs. So to understand CMR and why you use it heavily a lot, the distribution of scar in cardiomyopathies is very different depending on the type of cardiomyopathy you look at. The classic ischemic, so the classic ischemic cardiomyopathy will start with a scar on the endocardium and slowly increase the engulf the epicardium too. Big MIs are full transmural scar. But then you can see, there it is. Okay. But then you see that myocarditis or sarcoidosis actually can hit anywhere in the heart: epicardium, endocardium, mid-myocardium. A lot of non-ischemic substrate is actually distributed mid-myocardially and mostly septal, sometimes free wall. But the reason we need to understand the distributions of these scars is that we think of VT ablation as this two-dimensional thing. There's a circuit that goes, but actually it's a 3D. Isthmuses are actually in 3D because the full thickness of the heart. So you can have circuits that start on the endocardium and then roll around in the mid-myocardium. You can have circuits that are purely epicardial. You have circuits that actually start on the endocardium and they take a dive down to the epicardium and then back up. So really the scar is 3D distribution, and understanding it is very important to know how to approach these VTs. And MRI has been extremely, extremely accurate at the stage of defining scar and where it is, both 1.5 Tesla and 3 Tesla MRIs. Here, for example, in ischemic cardiomyopathy CMR, where you have the myocardium, the normal myocardium will be in black, the LGE will be in white. And then this is the classic distribution of an ischemic cardiomyopathy where you have most of your LGE on the endocardium and not fully transmural. Now, an MI that's bigger will be fully transmural. I'll show you an example of that later. Non-ischemic cardiomyopathy will have more mid-myocardial or epicardial distribution. So if you can see this is what we call the ring-like cardiomyopathies, where they show mid-myocardial scar distribution in the middle of the myocardium in a ring fashion. With LMNA hitting mostly the septum, filaminopathies hitting mostly the free wall first. Here, this is a cardiomyopathy with heavily epicardial involvement rather than mid-myocardial. When you see something like this, you have to be ready. If not, the only axis that you take is epicardial. You also have to be careful not to interpret the cardiomyopathy based on presence of CAD or not. This is a paper that we just published last year, end of last year, and we took a big database of patients with ischemic cardiomyopathy where we did MRIs on all these patients, and we looked at the distribution and the quality, the type of cardiomyopathy they have. You'd be surprised that 17% of these patients, although they had CAD, they had either pure non-ischemic cardiomyopathy on their MRI or a combination of both ischemic and non-ischemic cardiomyopathy. We use CMR pretty heavily to define these substrates because, again, targeting these circuits makes a big difference. So you want to know going into the case whether you need to be ready for an epicardial access or not. So selecting the optimal approach. So the LGE has been found in 96% of successful ablation sites throughout the multiple studies that I here mentioned. The epicardial LGE had an 85% sensitivity and 100% specificity in predicting epicardial location of a VT. It's mostly in non-ischemic cardiomyopathies, but also in ischemic cardiomyopathy. For ischemic cardiomyopathy, the transmural nature of a scar on a CMR will increase drastically the likelihood that you might be dealing with an epicardial circuit. It can go from a risk of about 5% or 4%. When you have transmurality, 40% of your circuits can be epicardial. We also thought that in ischemic cardiomyopathy, the majority of the epicardial circuits are in the inferior wall, but that has been debunked recently in the last 10 years or so. You can have epicardial circuits actually anywhere, not just in the inferior wall. This is an example of a non-ischemic cardiomyopathy. We did an MRI. This is a patient that was ablated 4 times before being referred to our center. He was actually referred to us not for VT ablation, but for VAD and transplant. We look his EF, actually from heart failure standpoint, he was doing fine, but he was in VT storm. We look at his MRI, and we see the mostly epicardial scar distribution heavily on the lateral wall, but also in a circumferential fashion on the free wall anteriorly and posteriorly. Going in, we got access, epicardial access from the get-go with this patient. We did not waste time doing even endocardial ablation and mapping. Let's see if I can. Oh. I'm not sure how to turn on the videos here. That's fine. Let's just continue. Sorry, so basically what these circuits... Huh? Yeah, I think because this thing is... I prepped it on a Windows-based computer. Okay. Yes, continue. Yeah, someone is remotely moving this. Okay. So what I wanted to show, we defined pretty much 9 circuits completely epicardial. We ablated all of them. He's still at home now, not needing any VAD or any transplant. But this is an example of a patient where an epicardial distribution on the CMR guided us to do epicardial access straight from the get-go to ablate the VTs. This is another example of an ischemic cardiomyopathy. This is a suboptimal picture. This is a patient who had an ICD, but this was a suboptimal picture, but there is almost a transmural scar in the inferior wall. Going in, we were ready to go. When you have a 40% chance of being epicardial, you prep for epicardial access from the get-go. And for this patient, we mapped this one patient also was ablated multiple times, and believe it or not, most of her ablation were done on the septum for some reason. She had clearly, if you look at the small signals and build the activation map, you have a VT on the inferior wall of the heart. This is your mitral valve, the apex. And the VT was exiting inferiorly close to the base of the heart in a kind of a small aneurysmal area. When we first started ablating, it took us about 15 seconds to try to break the VT or even slow it down. That was also a signal for us that we needed to go epicardially. And as soon as we went epicardially, now the VT slowed down because what we did on the endocardium, and we caused a little bit of edema. But here we were able to actually locate a channel all along. We put a DECA nav in, and if you see, you follow these little signals, we were able to actually induce both antidromic and orthodromic VT through the same channel epicardially. And after ablating this here at the start of the channel, actually the whole channel shut down at the same time, making this VT non-inducible anymore. She's actually more than a year out now after an ablation with no recurrences whatsoever. Oh, this is working. Okay. So LGE CMR also helps us figure out the ultimate approach to the circuit. This is a paper published in 2020 looking at the distribution of scar within a CMR. So this is a protocol where they define the scar, and they look at the distance between the scar and the sides on the endocardium or epicardium, or which side of the septum the scar is. And they create an index where they can divide this. For example, this piece of the scar is more endocardial. This piece of the scar is more mid-myocardial. So this is less than 3 millimeters to the endocardium. This is 3 to 5 millimeters, and this is more than 5 millimeters, and it would be less than 3 millimeters out of the epicardium. So if you have a VT, and then that could be segmented into the MRI. For example, you can divide it into three strata of data. This would be in green here, for example, is what part of the scar is actually closer to the endocardium, what part of the scar is mid-myocardial, and what part of the scar is epicardial. This could be integrated with the mapping system, and you can actually decide how to target your VTs based on these distributions. So for example, here, this is more a crude way to do this. This is more a computed way to do it, but this is more a crude way to do it. When you see a mid-myocardial scar that's closer to the left side endocardium more than the right side endocardium, you can deliver ablation on the left side of the heart, on the left side of the septum. If you have a scar that's more right-sided and closer to the right side of the septum, then you can focus delivery on the right side of the heart. And a matter of fact, too, just finding the mid-myocardial scar here will signal you to do biventricular mapping from the get-go. So you go in and start with the RV mapping first, and then go to the LV mapping first instead of jumping to the LV map alone. There's also data on trying to segment the vessels around the scar to see if we can avoid getting epicardial access, or if the epicardial access is in areas that we can't get to. For example, the base of the heart. The base of the heart is covered by fat and vessels that you don't want to hurt, the coronary arteries. So this data looked at the proximity of the coronary vessels, the coronary sinus venous side. And if your distance is less than 9 millimeters to the scar, there's a very good chance, more than 70% chance, that you're going to find a potential there or late potential there that you can target for ablating these VTs. We actually just did the recent one in a congenital patient. I did not have the slides to show it for today, plus we have a very limited time, so I could not include all these cases in. But we were able, we mapped a VT that was exiting on the right base of the septum, entering on the left base of the septum, and we were able to map it from the middle cardiac vein right in between the two. This area is specifically useful because doing epicardial ablation for this VT, you won't be able to be able to get to the circuit because it's all covered by fat, and you have the RCA or a distal circ there that you don't want to hurt. Now, how does LGE CMR actually perform over the voltage map? Why are we doing the MRI to start with? Why don't we just do voltage mapping? And that would replace what we can localize scar. Well, the classic voltage mapping, and especially the cutoffs that we use between 0.5 and 1.5, are not that precise in locating scar, especially in non-ischemic cardiomyopathy. As a matter of fact, you need 2 millimeters of thickness of normal muscle on the inside of the heart to eliminate any low voltage on your voltage map. So you can miss an entire scar with just 2 millimeters of muscle on the inside that's healthy and having signals. The study here looked at how much thickness, the correlation between scar on MRI and scar on EAM, on the electroanatomic mapping. And unless you have a totally normal heart or fully transmural scar, the EAM lacks utter accuracy. So right in the middle, anything in the middle between the full transmural scar and the normal heart, there is no discriminatory power to doing a voltage map. The same both on the endocardium and on the epicardium. And it's even worse when your scar is heterogeneous to start with. So this is assuming that this is a very solid scar, completely white on your LGE. But if you're on your grayscale on the MRI, meaning the scar is already heterogeneous, it's not complete, it's even worse even at the edges of that spectrum. So your electroanatomic mapping misses a lot of scar, especially in non-ischemic cardiomyopathy. Now, take it one step further. This study published, they looked not just at late potentials and low voltage at baseline during sinus rhythm, but this is positive extra stimulus delayed activation. So what you do in this protocol is you can see these little fractionations at the end of a QRS. They don't count as a late potential because they're all within the QRS when you map. But if you introduce extra stims, especially double extra stims, you can stretch these late potentials out to reveal the late conduction. As a matter of fact, if you look at the core, so this is the core, meaning this is the solid scar considered as a solid scar, versus border zone versus totally healthy, defined by either EAM or MRI. The distribution of voltage of these little potentials correlate much more with an MRI distribution of a scar than a conventional electroatomic map, voltage mapping, telling you that MRI will give you a lot more information as far as scar location. We were discussing earlier today, what we do with this is, usually when I have especially non-ischemic cardiomyopathy, I build the voltage map, the classic one, and then I look what the MRI has scar on in the LV, and I change the wavefront of activation of the heart. So I pace the opposite direction, and I rebuild the map based on these late potentials. To save time, I focus on the area where the MRI showed me there is mid-myocardial scar or epicardial scar. And I can do this too, both on the epicardium and endocardium. Furthermore, there's been newer software now looking at trying to define active channels of slow conduction based simply on an MRI. So for example, this is a protocol where they look at dense scar versus non-dense scar, and they try to find isthmuses that you can target during ablation procedure. You can include these with your 3D mapping system depending on the package that you look at. And they've been correlated and studied versus the electroanatomic mapping. So currently, we don't have any randomized data whether CMR versus EAM will have a better outcome. However, we have a lot of retrospective data and some prospective data showing that the scar localization on CMR and integration during the VT ablation was associated with less recurrence rates and a better acute outcome for both ischemic and non-ischemic cardiomyopathies. There is actually some data now with dechanneling. Dechanneling basically is similar to what we do with substrate modification in a voltage map, but instead you use the additional information you get from CMR, integrate it with your map, and then dechannel based on the MRI too, not just on the EAM. As a matter of fact, this dechanneling method will give you more areas to work on that otherwise would be totally dark on EAM. And there is a recent study that compared not just dechanneling based on MRI helped with EAM. This is dechanneling based on MRI alone. So what they did is they had 3 groups of patients. One patient did the classic substrate modification without help from the CMR. They did the group B here was CMR aided. So they did EAM and CMR, and they dechanneled the patient, versus CMR alone. So you register it based on the aortic anatomy, and you actually dechannel the patient purely on the MRI data. You don't look at voltage mapping. And what they found is the recurrence rate with CMR guided alone, surprisingly, was slightly better, but not significantly better than CMR guided. However, when you don't use any CMR data, your outcomes become immediately worse. So using CMR, whether alone or in combination with a voltage map, is clearly superior during VT ablation. Hence, the most recent expert consensus, although some of that data came after 2018, 2019, they gave a class 2A indication to consider an MRI, especially for non-ischemic, but also for ischemic cardiomyopathy in patients who are considered for a VT ablation. So we talked about cardiac MRI. How about CT? So CT has much greater spatial resolution compared to MRI. The MRI has, on average, about 1.4 to 2.0 millimeters versus 0.5 millimeters for the CT. It is extremely helpful in determining the course of the coronary arteries, the phrenic nerve, the epicardial fat, and pap muscles. There is very good correlation with electroanatomic mapping, with voltage mapping, when scar is transmural. However, when they looked at non-transmural scar, the correlation was much poorer compared to CMR. And this is one of the protocols on CT that they look based on the wall thickness where those isthmuses could be. And there are limitations to this method. However, there are newer software packages that are coming out that I'm hearing that they perform better, but I haven't seen them commercialized in a wide fashion yet. This is one of the uses that we do for MRI. This is a patient for a CT scan. This is a patient with pulmonary atresia and Rastelli procedure. She had a VT, and we wanted to define the coronary artery course, the aorta, the position of the Rastelli compared to the scar. And we wanted also to make sure that the area where we're interested in to ablate the VT, how far away is it from the RCA coming behind it? And it was far enough for us to attempt high power, because this was an isthmus that simply did not have any signal in it. There's a very thick scar, so you'd have to deliver very high power for a very long time. So you want to make sure the RCA course is away from that spot. Intracardiac echocardiogram is excellent for identifying LV thrombus. You can actually use it live. We've done a few cases with LV thrombus in the heart. We did for incessant VTs. You can watch your catheter, stay away from the thrombus all the time, but you can do a patient with an LV thrombus present in the heart if they have an incessant VT. It's excellent to define wall thinning, aneurysmal segments, both epi and endoscar. There is a patient we had where you could clearly see on ice without even an MRI. A patient who lived distantly could not do an MRI, so on ice you can define epicardial scar pretty easily sometimes. Look for structural relationships. A lot of VT ablations that will get referred to us. For epicardial ablation, we go in and they simply missed an isthmus between a scar and, let's say, the corner of the mitral valve. Those areas are very tight. Ice will help you make sure that you got to the edge of the mitral valve when you map, so you don't miss an area like that. Monitoring complications, you ensure adequate anatomical mapping and contact. During ablation, it's invaluable for papillary muscle and moderator band PVCs and VT. It does correlate well with voltage mapping on multiple studies. There is some health billing data that it does show reduction in VT recurrences and readmission rates. But that data, as you know, health billing data is not the best data used for these. This is an example of a sarcoidosis patient with a little bit of an aneurysm in his septum. When I go in and look at a patient with sarcoidosis and I see this aneurysm, I already start looking at the location of the VT. I know it's going to come from around that area. So you can focus your mapping there. Despite the fact that you only have the exit, the entry was hidden here among these earlier potentials, and we were able to concentrate our contact based on ICE, ablate the VT successfully there. This is another use for ICE. This is a patient with ischemic cardiomyopathy, an inferior aneurysm. After an inferior MI, he had a VT that was rotating. Actually, he had both antidromic and orthodromic around the scar. And then looking at this, we had some signals on the intracardiac side. They looked a little bit far-fieldish. We could not even entrate them at high output. That tells you that ablation there is going to be difficult. We tried an ablation endocardial, we couldn't. But what does ICE tell you? You see this aneurysm here, you see the wall of the septum, and you see the RA right there. So what we did, these are the signals that we got from the endocardium. They look nice. We can drag and train them, even at high output. You can see it's walking through. These are the signals we saw from the middle cardiac vein, proximal middle cardiac vein, or even start of the CSS. So by going there, by just seeing on the echo, this wall was facing this side. And we ablated successfully the VT from that corner. And finally, the use of ICE for pap muscle, PVCs and VTs. I'm showing this because this location, And that location here will look exactly the same on 3D mapping, because the system is going to just push all this data to the wall, so it will look all the same. It's imperative to use ice to make sure that you're on the pap muscle when you're doing these ablations. The same with moderator band PVCs and VTs. This is a patient that I had actually mentioned Dr. Narsian before, a patient with PVC-induced DF, and we were able to map and with cartosound localize the moderator band and ablate with both RF and cryo for this patient on the lateral edge of the moderator band. With this, I end my talk. Thank you very much. Sorry for going over a bit.
Because a lot of fascinating cases, and I think very convincing demonstration of the utility of imaging, especially CMR, for pre-procedure planning and planning the ablation. Any questions? Anything?
So the biggest problem that we face for pre-procedural CMR in India is that with the ICD lead inside, most of the MRIs here don't have the program for, otherwise there are too many artifacts. So, I mean, where do you think this is all going? Because there are so many patients with ICD leads inside, and I don't think there are too many, MRIs with the particular software. So, is it going to improve somewhere, or?
Yeah, so there are multiple softwares that are available now and multiple protocols to do it. You don't necessarily need the software for this. You just need a protocol into the MRI machine. What you really also need is an MRI operator willing to do the MRI too, from what I hear mostly. But you can get very good LGE signals from it. We've been at the U doing now patients with retained leads, capped leads, epicardial leads, all sorts of leads with 0% events for the last 8 years or so. We have specific readers even within the university that we test them with these things, so they got us the read. And you need also an MRI reader that you know very well. This is a read that you're not going to show up at 3 p.m. and read it. This is a read that you're going to show up during acquisition, talk to your tech, tell him that I don't like this, change your inversion time, change your widespread to get good images. So not only you need the protocol for it, you need the right personality for it too.
I think, Andre, they are talking about a particular problem in our country. We don't have wideband MRI. That software is not there.
Yeah.
So now we have a good data on CT LG. The data is there. So we can do LG with the CT scans, our regular CT scans. If you use LG, the images are not bad. We have tried here as well. We can start using it. It will give a fair information for the scar distribution. It's not as neat as our MRI images, but it still helps us.
So I have a question. So MRI is anatomy. It defines the scar. Then the late potentials and lavas define the physiology, the channels. So if you find a scar and on electroanatomical mapping, you don't find those potentials or charging despite pacing the RV or in the opposite direction, are you justified in ablating those areas? Because they may not be the right areas to ablate.
Yes. So there is some protocols now. That last study that I showed actually targeted them with or without induction. So if you induce, you have your answer a little bit better because you know where the VT is coming from, and you can choose to target it epicardial or endocardial based on the distance of that scar to the epicardium or to the endocardium. There's been studies that targeted these areas based on the SDI alone. So basically, if you have a scar that's closer to the endocardium, you fuse it with a map. If the part of the scar that's closer to the endocardium, you ablate endocardially, you modify it endocardially despite the fact you don't have these lit potentials. And that part of the scar that you have that's closer to the epicardium, you can ablate epicardially. You can use other ablations for the mid-myocardial scar, but it does have, unfortunately, less. So I always tell my patients plan A, plan B, plan C, plan A, which is I ablate, I induce the VT, I see it, I map it, and it goes away. But unfortunately, that happens in 10% of the time. The plan B would be I see the VT, it's unstable, I take them out of it, I map, I figure out where it's coming from based on those lit potentials or based on pace mapping. And I modify based on the data from the MRI and test for non-inducibility. But there is a subset of patients, unfortunately, about 20 to 30% of them where you can't induce. And those, unfortunately, it's going to be the same result of you're making guesses, and you can't, your outcomes will be less if you modify it that way. But the other concern with this is, are you creating a VT sometimes when you're doing this? And unfortunately, I've had the opportunity to create a couple of them. You ablate them because you know where they are, but you can create, unfortunately, circuits if you're having that approach. So it is still limited.
Thank you very much. In the interest of time, we must move on to the next talk, and there's a slight change in the program. I would request Dr. Venkatesh Krishna to come for the next talk, which is on intramural VTs. So Venkat is online. I don't see.
Yes, I think they're going to play the video if I'm not mistaken.
Yeah,
Already sent the.
we can see you now, and they had mentioned intramural, and I can see yours electrogram-based approach on VT. That's fine. So welcome to the program, and it's nice
Thank you.
seeing you here.
Nice to see you.
Would have been better if you had been here. Let's let's move to the talk, and let's hear you out.
Okay. Are they playing it?
Yeah, we can see your slides. Can we have
Okay.
it on the
No,
main screen?
I don't see the slides here, but
Can we see the slides on the main screen? Just 1 second. Yeah, we can see it now.
I am Dr. Venkat Tolakanali, Professor of Medicine from University of Minnesota. I'll be discussing today intramural ventricular tachycardia ablation strategies. So these are there's no relevant disclosures related to this topic. So when we think in terms of intraseptal or intramural ventricular tachycardias, why is it so difficult? And apart from the strategies that we use in order to get to where we are successfully, we need to understand the substrate. We need to understand the electrical as well as the pathological substrate. I wouldn't delve into the details, but just keep in mind in this particular slide, what I'm describing is an ischemic cardiomyopathy, although it is useful to understand even in non-ischemic substrate as well. When you look at the substrate, the scar distribution, what you actually see in the intramural location can be quite non-homogeneous. When you are mapping endocardially or epicardially or on either side of the septum, the channels through which the ventricular tachycardia seem to go can be quite perpendicular and quite tangential. So this is something to keep in mind in your when you are thinking in terms of how to target these lesions. So imaging to target precise location is extremely valuable, and this will be discussed by other speakers in this symposium. Let's look at a little bit about the septal VT characteristics and the substrate. Della Bella described in heart rhythm in non-ischemic substrates, and this is an example on the left panel. What you are seeing is a ventricular tachycardia where 50% of these patients have RS ratio of 1. That means 3 out of 6 leads were seen to be the case. Then the other one, which is classically described as the pattern break in V2, this is common even in the summit VTs, but in the centroseptal location, that pattern break seems to be also very helpful in this situation as well. When you look at the voltage maps, whether you are thinking in terms of looking at bipolar voltage and unipolar voltages, endocardially and epicardially, when you look at it, if the substrate in the bipolar voltage looks small and the unipolar voltage looks bigger, and similarly the epicardial voltage is small and the unipolar voltage looks bigger, we are already thinking in terms of having a scar in the mid-myocardial region. This gives you an idea where we are actually looking at the septal substrates or the intramural substrate. This is a very nice example described by Della Bella in the heart rhythm in the non-ischemic cohorts. If you look at the unipolar voltage in the successful sites where they ablated, they were falling into the 5 to 6 millivolt range in the unipolar substrate, where bipolar looked like there was nothing there going on in that location. And the activation, if you do the activation mapping, it also falls into this border zone of the unipolar voltage as well, if you are lucky to have a activation mapping that could be performed. The substrates also fall into the other things what we can actually look at if the substrate is across through and through is the late potentials looking at and the lavas. They are also very useful in this situation. With that in mind, we already know the concept of what we call as a fast Fourier transform. This is the mapping of looking at the frequency signals in terms of power, dominant versus the peak frequency. Peak frequency has already been described in the endocardial or the subendocardial region. But if you look at, we looked at it in a different angle. We looked at the dominant low frequency signals with a high energy. When you look at that particular type of a situation, what we found in the successful areas where we have ablated using all the techniques what we actually are describing in this particular talk, we found that the low frequency signals corresponded very well to the area of the substrate where we actually found to be the case. And this also falls into the same unipolar voltage what is described by Delabella, but even more precisely you can actually look at the substrate very nicely using this technique. This could also be emphasized using the ILAM of these low frequency signals. So strategies of mapping. So if you're lucky enough to see a ventricular tachycardia which is hemodynamically stable and you can map on either side of the septum to look at where this exactly exists, this particular area could be a very useful target for an ablation procedure. Having said that, not always it is possible to do an activation mapping, so adopt other techniques. One of the techniques that we can use is the septal perforators of the coronary arteries. Using the septal perforators, you can actually insert the wire, insulated wire like a vision wire or a wire covered with a balloon and expose the tip. You could also make an artificial bipolar type of a map by using a double wire technique. And this can be used both in the arterial and the venous structures in order to get to these intramural or interseptal substrates. But obviously, you are very much largely limited by the location of these arteries or the veins. With that in mind, we actually paced, in this case, in the vision wire, and demonstrated the VT closer to the morphology similar to the VT morphology. Keep in mind, we are limited by the anatomical location. You may not get exactly 100% location where we are actually targeting. So infarct-related VTs, if you have a substrate and you can pace and look at the morphology, and it continues to be the case in the septal perforator and the entry and the exit areas, you can actually track these by stim to activation timing. In this case, stim to activation is longer from the LV side, shorter in the RV side. Septal vision area is the mid-myocardial region. This track is somewhere in this region. So keep that in mind. These tracks may not be right across the septum. It can be quite tangential. In this case, this particular patient, it was from the basal inferior location to the right ventricular outflow tract. With that in mind, we started to look in a different angle. We validated using a vision wire placed in the septal perforator. And if you have catheters on either side of the septum and pace, and individually pace and capture and make sure it captures, and after that you pace and create a fusion pacing, and if the morphology matches to what we see in the vision wire, then it is quite similar to the VT, then we are in a good target location without having to go through the vision wire, which is largely obviously limited by the anatomical constraints. Now, this particular paper described in Heart Rhythm by Bhaskaran, what they did was looking at the late potentials in the endocardial region and the pre-potentials in the epicardial region, and what is there in between is the mid-myocardial location. In this case, how they validated was use the intramural activation using the needle mapping in an explanted heart and found these potentials in the mid-myocardial region. So you can actually map these diastolic corridor, but if you can demonstrate on either side of the wall by showing the later, the pre-potentials. So treatment options, what do we have for treatment options? One of the treatment options, as we described, when you have a path to go through the coronary arteries or the veins, you can actually potentially use these as targets to inject transcoronary ethanol. So this can be done, elegantly described very early by and Hein Wellens, and Brugada several years ago, and after that, Dr. Stevenson has used quite a bit in many patients to have a successful outcome. This could also be used in the venous circulation as well, the coronary venous method by Valderrabano, and extensively. What are the constraints of this problem is the non-homogeneous nature of the scar formation, which is well known in the hypertrophic cardiomyopathy as a potential chance for proarrhythmia. What we did in an unischemic cardiomyopathy thin wall patient in a situation where we did not feel right to do alcohol was, after mapping through the septal perforators, we actually embolized a coil to create a smaller zone of infarct. But in order to know that you are for sure you're in the right direction, you can inject cold saline to demonstrate either slowing of the VT or termination of the VT. Then you can actually deliver this particular coil in that location. So the early description of needle injection was done by Taglingam and Ross from Australia in the surgical technique using the cooled needle ablation, which creates a deeper and a very nice lesion when you know where the ventricular tachycardia is arising from. With that in mind, the irrigated needle ablation was designed, originally shown by Dave Callens, and subsequently the Bordeaux group and also Bill Stevenson, Usha Tedrow, they have demonstrated this in much larger cohorts being studied successfully. Once again, you are limited largely by the mapping issue. That's a major thing we always tend to struggle in this group of patients. Once you know all the criteria that you have met through the mapping techniques, I think you can target these much more effectively. With that in mind, Doug Packer showed in the late-breaking trials in the heart rhythm several years ago, using a technique called the SERP, which is the Saline Enhanced Radiofrequency Ablation feasibility study, using the heart saline injection and the RF energy as a potential concurrent RF energy to cause lesions in the intramural region. And it did not so far took off as a good modality at this point of time. Is a potential modality which could be used in a difficult situation. So the UCLA group, in a patient, they demonstrated using the reentry system, the Stingray reentry system, which is used for the CTOs, to penetrate into the intramural substrate through the coronary perforators and use the radiofrequency energy with a saline bath, within the saline bath, using the ablation catheter, successfully ablate a VT. With that in mind, we were mapping through the coronary venous system, and we have done several of these cases like that. And once you map in this area, sometimes alcohol injection is very difficult because of the size of the veins. In that situation, you could do exactly the similar way, dipping into the saline bath and ablating through the ablation catheter, or even use the Bowie, but the wire has to be insulated. In this case, you can use a microcatheter as a insulation as well, in addition, so which we can actually deliver the lesion and potentially successfully terminate. We are largely limited when you are actually ablating through the unipolar ablation method the depth of the lesion. That's one of the things which can be achieved by using a bipolar ablation technique, where you can actually cut across the wall to actually go through the substrate much more effectively. In this case, the bipolar ablation, after we identified the location and was done, and the ablation, the VT was terminated, as you can see. So with this bipolar ablation technique, which is being available, we actually put together a multi-center study, and we looked at 47 patients in our cohort, 32 from our center, UCLA, 7 University of Colorado and Stanford University, and we looked at these number of patients, and they are all comers, ischemic and non-ischemic group of patients. The acute procedural success rate was about 94%. The only main complication due to bipolar by itself was the atrioventricular block, which you can expect is a potential reason which can cause, but at the cost of, by the heart block, we were able to at least eliminate these VTs, and the other minor complications were seen, which were managed appropriately. The acute success rate, this is more than 3 years data, as you can see, is up to 54 months of data is present as the maximum. So 55% success rate was actually very good in the sick group of patients, and 5 patients needed a repeat bipolar ablation in this cohort. The other techniques that could potentially be used is the SBRT, the stereotactic body radiation therapy, with a precise planning and looking at the substrate. Although this is kind of gaining importance, it's in slowing the process because of many constraints that we actually come across with this problem. So in conclusions, ladies and gentlemen, pre-procedure imaging is valuable. I know one of our co-speakers will be speaking in this aspect. Intra-procedural substrate definition is extremely valuable, and pacing the techniques with the different methods using the intracoronary method as well as the transmural fusion pacing may be very helpful. I didn't touch upon the half normal saline, which also is another technique to actually penetrate the lesion much more deeper, including the sequential versus simultaneous unipolar ablation in addition to bipolar ablation as a potential method that you could use, and of course all other technique within the coronary, including coil embolization as well as the needle and heart saline ablation, can be done successfully to treat these intramural substrate type of patients, difficult patients otherwise to encounter. Needless to say, in very difficult fast VTs, we could use cardiac sympathetic denervation if nothing works as a complementary to these kind of ablation procedures. Thank you so much for your attention.
So wonderful lecture. Can you hear us?
Yes,
So
certainly. Yeah.
So my question is that when should you think, there are two questions actually, when should you think that you should now have reached a stage where you should start mapping these septal perforators? One is the ECG criteria that may or may not be very sensitive or specific, but during the mapping, what clue gives you that, look, I have to go to the septal perforator?
Very good question. I think as Henri earlier alluded, I think pre-procedural imaging seems to be extremely valuable. There are some new data that is emerging. We are looking at, a new company actually has come up with an idea using the artificial intelligence, using what is called a vector mapping. So that seems to be kind of promising down the road. But what we have so far done, and actually surprised, is the so-called ischemic cardiomyopathy. When we think in terms of particularly inferior infraseptal VTs, seem to be very high incidence of association of these scars actually extending into the mid-myocardial region, and our threshold is relatively low to really map in those areas. Partly because if you keep mapping and trying to ablate and the VTs keep recurring, you have to think in terms of potentially mapping on both sides of the septum. That's what it seems to be the common theme that we have seen, especially lack of successful ablation is one of the reasons. The non-ischemics, I think the threshold is even more lower because of the pattern of the scar distribution. I think it's a combination of several things which actually drives us that way. I tend to rather try to see if I can put in a coronary sinus catheter, and that may give us a clue ahead of time, looking at not just these areas of intramural substrate, especially two French catheters. You could also do the epicardial location as well. So I think these are all the different, the thresholds that actually draw apart from the ECG criteria is a little bit difficult with the non-ischemic cardiomyopathies because it's not very superly proven to be the case. But I think, if the infraseptal scars, if you see, are anteroseptal scars, you have to keep thinking in terms of septal origin.
So Venkat, in interest of time, I'll have one small question and then we'll close this. Can we use a microcatheter and a routine PTCA wire to map by using a clip? Microcatheters provide that insulation, and the tip of the wire would be in the septal perforator. So using a normal regular PTCA wire and having a microcatheter.
Absolutely. Yeah, you're absolutely right. PTCA, I use it quite often. Actually, you can put in a microcatheter you are an interventionist too. You got a multi-talent. I think that is one of the things I think I learned from the interventionist, using a microcatheter, exposing the tip. And you can actually keep a little bit smaller tip so that in that way you don't need to have a bigger, like a vision wire or other catheters. And especially in a smaller branches perforators, you may not be able to get in with bigger than two French catheters. So that's possible, yes.
Thank you, Venkat, for a wonderful lecture. Really enjoyed it. I know it's very early in the morning there. Thank you very much, and most welcome to be here.
Thank you so much. It's delightful to be present. Thank you.
So we'll have Dr. Sanjay now. So Dr. Sanjay, you are there? Dr. Sanjay needs no introduction. I think he's well known to everybody here. He's a pioneer in the field of VT. So welcome, and can we have your talk now?
Good morning, or good evening, I guess. Can you hear me?
Yes, we can hear you clear.
Terrific. Well, thank you very much, number one, for the invitation, and Narasimhan. And of course, it was a great pleasure to hear Venkat give this talk, which deals with a very critical aspect of VT ablation, which is the intramural substrate. And so my topic is on activation mapping techniques. And since this is a forum where we are discussing VT in the setting of structural heart disease, I'm going to focus my talk really on activation mapping for reentrant ventricular tachycardias. So this is a slide that I borrowed from Dr. Stevenson, and this is kind of how he conceptualizes reentry, with the healed infarct serving as the prototype. So the point of reentry when you have underlying scar is that there is channels within the healed infarct, which basically serve as the areas through which activation wavefront spins around. And this is the model that Dr. Stevenson conceptualized nearly 30 years ago, and then came up with his technique for really identifying the different components of the VT reentrant circuit through entrainment mapping, which everybody is familiar with. The essence of entrainment mapping is that you have to sustain the ventricular tachycardia, and during that, you perform pacing maneuvers, and then when you terminate pacing, the tachycardia resumes, and through an analysis of the ECG match during pacing versus tachycardia, as well as measurements at the site that you're pacing from relative to the VT cycle length, you can deduce whether that location that you're working from is the entrance, isthmus, or exit. And the goal here really is to identify the isthmus, which has been shown reproducibly to be the target for successful ablation of these tachycardias. Now, when Dr. Stevenson came up with this concept, we had very primitive tools in terms of our capability for analyzing the signal, and yet this concept still stands the test of time, which is kind of a reflection of just how good and critical this work was. But now, in the last 5 or 6 years, we have come up with more advanced tools that can allow us to really define the substrate, as well as perform a very detailed high-density mapping through these multipolar catheter platforms. And almost every vendor in the field has a tool that can provide this kind of mapping. So for Carto, they have the Atrial, Abbott offers HD Grid, Arrhythmia mapping has the Orion Basket, and all of these catheter platforms comprise of multiple electrodes that are closely spaced. The dimensions of these electrodes are much smaller than what we typically see in an ablation catheter. So this combination actually provides much better signal resolution. And also the multipolar platform can acquire the map relatively quickly, so that allows for very efficient mapping. Now, the vendors will have you believe that these bipolar tools, where there are multiple electrodes in such close configuration, have advanced mapping capabilities, and that is true. They do resolve the signal utilizing a combination of directional mapping, as well as trying to validate information not from just one bipole, but a combination of bipoles in a geographic area to look for consistency. They also combine bipolar with unipolar mapping, which they believe then allows a better understanding of wavefront activation and signal sampling. But what you have to be also cognizant of is that when a system is doing all the analysis and you're having multiple points where manual annotation is challenging, you have to just be somewhat skeptical in terms of what the data is being shown to you. So what I'm going to try to do over the next few minutes is show you some of the usefulness of these platforms, but also kind of caution you in terms of why you have to still validate the data that comes out. So here is kind of the slide that Dr. Elad Anter has lent me, but this was a part of his paper that came out in Circulation in 2016, wherein a combination of human ventricular tachycardia as well as a porcine model of healed infarct ventricular tachycardia, which I'm showing in the example here, he validated some of the observations that Dr. Stevenson had conceptualized. And here's just a beautiful representation of a reentrant wavefront that seems to funnel through this location and create a figure of 8 reentry, sort of a classic model of a reentrant ventricular tachycardia. And this was created using the Arrhythmia platform. You can see just by the number of points here what a high density map it is. And so this is, kind of what a well executed map of a tolerated VT can provide us in terms of information of the reentrant circuit. Now, the same can also be replicated in a human VT. And so this is a case that I did a few years ago where a patient with apical healed infarct presented with VT storm. The tachycardia was well tolerated. And so it allowed us the capability of being able to really perform activation mapping using some of the tools that we talked about. In our case, we used the optral catheter technology. And this is kind of what the activation of this particular tachycardia looked like, where you can see the wavefront kind of coming through the septum and entering the scar on the anterior septal aspect and exiting inferiorly, which is consistent with what you would expect from the 12-lead morphology of the tachycardia. So both in humans and certainly animal models, you can use activation mapping to understand the reentrant wavefront. But I think it's just equally important to understand the challenges, and that's what I'm going to try to share with you in the next few slides. So here is another patient who had a posterolateral infarct and was experiencing recurrent VTs. The ventricular tachycardia consistent with the location of the infarct is shown here. It was relatively well tolerated, cycle length of about 400 milliseconds, which allowed us to perform a detailed characterization of the tachycardia relative to the substrate. So here are 2 examples of recordings that were made within the scar during ongoing tachycardia. And I'm going to highlight the local electrograms that were sampled with the ablation catheter here. So any of the mapping tools that we use, the automated algorithm or the automated sampling by these technologies typically tend to record the highest or the largest local electrogram. But we know from our own experience that the largest electrogram may not necessarily reflect local activation. So that's the first thing to be mindful of. Now, there are very simple ways for this to be resolved, and the technology that's typically used is the window that you can narrow to ignore this particular electrogram and only sample something in the diastole, and that for the most part seems to work when you have this kind of a local electrogram. However, when the electrogram dimensions are smaller, and in this case you can see it's an almost continuous recording, there the principle of creating a window to ignore the largest electrogram may not be effective. It's also important to recognize that within the scar, despite these smaller bipole electrodes, you may still have challenges understanding which signal or which component of this multipolar electrogram is actually the earliest. So now let's see how we could resolve this through entrainment mapping at the same spot. So this is the first spot that I showed you, and that was how the signal looked like. Now we've done entrainment mapping, and we know that this is a valid maneuver because the last paced beat advances the tachycardia, which is evident if you focus on the RV electrogram, which I oftentimes do. Now, where would you measure the post-pacing interval here? So your normal tendency would be to go to maybe the mid-diastolic electrogram, and you are probably not too far off. But if you want to be really precise about this, you could use the N-1 rule, where you look at the time that it takes for this pacing spike to reach the RV electrogram. And since this is concealed, you can kind of march back that same timing. And based on that particular march back or N-1 rule, it is actually this very diminutive area here that's probably where you are capturing. And if you measure that, that is very close to the tachycardia cycle length, and the stimulus to QRS here was about 50% of the total tachycardia cycle length. So this is an isthmus location. But unless you do this maneuver, this electrogram, you may not be. Now here is that second example that I showed you, or the second location. Once again, that's what the signal looks like. That's the last paced complex. Here you can see actually when you do measurements of the RV electrogram that you have actually advanced for one beat after. So this electrogram actually captures this QRS complex. But using that same approach where you measure from the pacing spike to the RV electrogram, go to the first beat of the tachycardia, march it back, and this is kind of where you're actually pacing from. You can get some clues of this because if you look at this during the pacing and look at this whole electrogram, this distance also lines up to what we are measuring here. And then with that in mind, once again, the PPI looks great, but this time the tachycardia, the stimulus to QRS is about 70% of the tachycardia cycle length, and that's an entrance location. But again, the point of showing you this is if you just used the automated feature, at best, the system would pick this maybe as the local electrogram and would most definitely ignore this. If it picked the other one, that would actually throw off the map completely. So that's the challenge. Now, in this case, obviously, we did some additional mapping. We were able to identify another location, which was an exit site. And through a combination of defining the substrate, performing entrainment mapping, we were then able to characterize the tachycardia in terms of how the wavefront was potentially spinning through the scar. But without entrainment validation, if I was just using activation mapping, I would probably not be able to define it as accurately. Now, different vendors do have certain features that can help. And this is a feature that's available in Carto. I'm sure most of you are familiar with this, which is the concept of ripple mapping, where actually there is a way to demonstrate activation and reflect the local electrogram by showing histograms during ongoing activation. And once you get into the diastolic phase, the big wavefront goes through, and now you'll start to see the smattering of these really small signals come through. That can basically suggest that what you're seeing in the diastole in terms of these very small fractionated electrograms, you can see that through these small histograms, then you can get a sense of the timing in terms of when it's happening. So that's one way to try to resolve this. I kind of would just briefly mention the study which we published late last year, and the goal of this particular paper was to try to use very high output pacing, 50 milliamps at 2 milliseconds through specially designed stimulators, which we use oftentimes during VT ablation, particularly in patients with dense scars. Because if you use traditional high output pacing, you may not be able to capture within the dense scar. And oftentimes you have to go very, very high on the output, as shown in this particular example, to be able to capture within the dense scar and identify components of the VT reentrant circuit. But the point of this particular slide is to show you that oftentimes when the scar is very dense and it requires very high output pacing to capture, the local electrogram is so diminutive that for any system, regardless of whether you're using a standard ablation catheter to map or one of these multipolar catheter platforms, the signal may be challenging to resolve. And if the signal cannot be seen, then it's impossible to assign activation. Another thing to keep in mind, and this goes back to our very old literature from 1998, this was the era of Field and Fox, when we would oftentimes see hemodynamically tolerated VT, which could be mapped. But when these patients would actually come for the procedure, even in this scenario, as many as 75% of the VTs were unmappable. So the point is that to do activation mapping, even with these multipolar catheters, you do need the tachycardia to be reproducibly inducible and tolerated, which is oftentimes the rarity. And then kind of want to end the talk with this particular slide, which is from a paper that Dr. Roderick Tung published just a couple of months ago, where he basically showed a concept that we have understood for a very long time, that is the scar is three-dimensional. And so the reentrant circuit, as we think about it, is really not that simple because of the behavior of the scar, and oftentimes some components of the reentrant circuit may be intramural, as Venkat just showed for the intraseptal substrate, but it's true for any scar for that matter. And in this situation, whether you're mapping from the endocardium or the epicardium, you may not be able to get all the components of the reentrant circuit. And so that's where activation mapping can be challenging, because you may see some parts of the circuit and miss out on the others, and you still have to kind of use your imagination to conceptualize how that reentrant wavefront is coming through. So to summarize, obviously we know that activation mapping techniques have improved, and the multipolar catheter platforms can certainly make this process more efficient. The challenge, anytime you have thousands of points, is how to resolve these maps. And that's where the system resolving it versus manual interpretation can be challenging, especially when you have a lot of points. And so in my opinion, you kind of have to still use the substrate to really give you a sense of where the circuit might be, use surrogates of the reentrant circuit in terms of late potential, especially if you can pace and demonstrate parity with the 12-lead ECG. And then, in my opinion, if the VT is tolerated, then entrainment is still the gold standard for really characterizing it. I think I'm going to stop here, and I appreciate your time. Thank you.
A brilliant talk. Thanks. Any questions from the audience?
Sanjay, I have a question. So let's say a patient has clinical sustained VT for which he used shocks. The tachycardia was 160. Would you straight away go for a substrate map and ablate rather than induce a tachycardia and then try to map this? So what percentage of patients you think a VT induction in the lab and going after a VT is better than substrate, or would you do a substrate ablation first and then go to induction of VT?
Yeah, no, I think that's an evolving practice, and I think different centers and groups have preferences. So we've always believed in characterizing the substrate, and that's kind of our approach for any VT, where we do this detailed electroanatomic map, identify scar distribution, as one of the earlier speakers was talking about cardiac MRI to complement some of the understanding of the substrate. But we do all of that, and in the lab, actually, we do identify the substrate. But our approach is a hybrid. So, just characterizing the substrate, and you're spending, nearly an hour to do this, is time well spent if you have some understanding of what the VT is. So we try to induce the VT up front. If it's tolerated, we'll perform entrainment mapping as we are building the electroanatomic map. If the VT is not tolerated, we'll terminate it. And then as we are creating the substrate, we perform pace mapping to identify matches for the VT. And then within the scar, if you can see decremental pacing to demonstrate a channel that can potentially mimic the VT morphology with delayed exit from deeper in the scar to the edge of the scar. So we try to actually induce the VT up front because it really complements our substrate map. And if the VT is tolerated, that's icing on the cake, because then we can do entrainment too. But that's our approach. We always induce VT. We never do empiric substrate modification for many reasons, but I also feel one of the important reasons is empiric substrate modification, you're doing a lot more ablation than what is necessary. And ablation, while it works to cure VT, if it is misdirected, it can actually create a proarrhythmic state. So that's why our approach is a combination of VT induction, using surrogates of the reentrant circuit through pacing within the substrate and doing all of that, but never just empiric substrate modification.
Right.
Thank you, Dr. Dikshit. So we'll move on to the next talk.
Terrific. Thank you.
Thank you. So Dr. Chung, next we'll have Dr. Fapo Chung speaking on ablation strategies for epicardial VT. So Dr. Chung, are you online?
Ladies and gentlemen, thanks for invitation from India. So I'm Dr. Zhong from Taipei Veteran General Hospital. I was assigned to talk about the epicardial VT ablation, when and how. So why we need to perform the epicardial procedures. So this is the illustration showing how complex of the VT isthmus looks like. And you could also appreciate that the involvement of the epicardium accounting for certain of the non-ischemic cardiomyopathy and also the ischemic cardiomyopathy. So when we started to ask about when to do the epicardial ablation, we need to understand which kind of cases that possibly that we need to do the epicardial procedures, such as the patient with the left ventricle, the thrombus, or with the mechanical aortic valve or the mitral valve. And the most important thing is consider about the disease entities, and such as the ARVC, PUGADA, and also using the ECG criteria. Later we'll discuss about this part, and also the image assessments. So this is the two different type of the non-ischemic cardiomyopathy, and you could also appreciate that the epicardial substrate seems to be more important in the inferior lateral type comparing with the anterior septal type. So several criteria have been proposed that possibly that the VT comes from the epicardium, such as the stirring of the QRS and with the delay activation, like the pseudo-delta wave, the intracellular deflections, the shortest RS complex in precordial layer to be longer, the MDI, and also once if you have the Q wave that belongs to the place that have, and you need to consider about the presence of the epicardial VT. So this is how showing how to measure the above mentioned criteria, and though some criteria seems to be good, but you still could find that actually the sensitivity and also the specificity sometimes is not perfect. So it means that even the ECG could be used as the guidance marker, but sometimes we still need to consider, especially we have failed endocardial approaches. The second is that the criteria initially proposed was traditionally used for the left ventricle, but not for right ventricle. So the PANS group also found that once if you have the Q wave in the lead one and also V2, will favor to be the anterior RV. And also inferior with the Q wave, probably you have the VT originating from the inferior RV epicardial region. However, since there is no very good criteria for the RVOT and also the basal RV region. So the next part is we could also use the endocardial substrate as the guidance, also published from the PANS group. Initially, they focused on the ARVC with the cutoff value from the endocardium to be 5.5, which was correlated to the presence of the larger epicardial substrates. And the same for the left ventricle, they also created a set up the voltage criteria to be the 8.3, especially for non-ischemic cardiomyopathy. So later, still some group using the point-by-point compare the endocardial mapping point and also the epicardial mapping point, and you could see the different cutoff ratios to be the 5.5 for right ventricle and the 4.4 for the right ventricle and 5.1 for the left ventricle. So the final part, before we move into the epicardial, we could also have the pre-procedure image. The majority comes from the cardiac MRI. And you could see that once if you have the more epicardial substrates, like in this case, which means that you will have more likelihood you need to have the epicardial approaches. And this kind of image processing, sometimes some patients could not receive the cardiac MRI. Sometimes we could also use the eyes detected the real-time scar pattern from the endocardium. And then it will also highlight it that potentially this patient need the epicardial approaches. So the second part that I would like to slightly short introduce how we do the epicardial approaches. So the first approach was described by the Sosa, Dr. Sosa. So before we do the procedure, we need to check the anticoagulation status using the traditional using the toy needle and using the lateral view, and also prevent the shears alone inside the epicardial space because sometimes the shears edge will damage the coronary systems or the myocardium. So this is the anatomic consideration, and we could do the anterior approaches or the posterior approaches. But when we do the posterior approaches, we need to be careful about the damage of the liver. Sometimes we'll create the liver hematoma and need a surgical intervention. So we need to compress the abdomen and also have the pre-procedure echocardiography confirm there is adequate space for the posterior approaches. So also before puncture, that we still need to understand about the patient's past histories, coagulation parameters. The real-time image guided will be very important, and also have the strong surgical backup. So initially we will place the right ventricle as the guidance with the one catheter placed at the RV apex as the guidance and toward the left shoulder, and try to prevent across the midline, because once if you cross the midline, you have the chance to damage the coronary arteries. And then gradually test a little bit, try to illustrate the shadows of your catheters. And once if you have the right ventricle puncture, you still need to slightly withdraw the catheter, the needle, and try to advance the guide wire. Just try to prevent repeated puncture, because repeated puncture sometimes will create a catastrophic effect. And also, the traditionally, even you use the RV, have the RV puncture, that the bleeding will stop without spontaneously within 30 minutes without any intervention needed. So then we could slightly test the contrast at the border of heart and try to gradually advance the toy needle. And some group also use the pressure monitoring. Once if you have to touch the RV free wall, then you will increase the pressure and suddenly drop once if your catheter, the needle move into the pericardial space. And the most important thing is that before we advance the sheath into the pericardial space, we need to confirm the guide wire have looping outside the whole heart, and try to prevent advance the sheath into the right ventricle if you have the RV puncture. The most important is that before you dragging back all the materials or doing further procedures, we need to also confirm that we place our sheath at the correct size without severe without puncture right ventricle and have the shadow outside. So the next part, I will slightly talk about some novel maneuvers for the epicardial puncture. So the first one is using the micro puncture caster. This is the micro puncture caster, and with the this is the Cook needle, and you use the micro puncture needle inside the Cook needle and gradually advance. So here is also the same with relatively the thin puncture lesions and prevent the severe RV bleeding once if you have the RV puncture. So the result compare the traditional SOSA techniques and the needle-in-needle techniques seems all the parameters seems to be similar, especially with regard to the complication created. The most important is that actually this is the practical and with less chance have the severe bleeds. So the second part, the second novel technique is what we call is the CO2 in the insufflation into the epicardial space. The first one is using the right appendage area using the micropuncture caster to from the right appendage sides and have the inflation of the air. You could appreciate here is air here. So then we just use the anterior approach with the needle puncture epicardial space smoothly. And also another group you also using the CO2 insufflation using the lateral vein, like in this case, they using the anterior. You could use the anterior lateral vein or the posterior lateral vein with the micropuncture caster. Created the puncture and also have the CO2 insufflation, and then just move the puncture needle inside. So this is novel, probably will not be available in some lab using the novel blind tip. So creation the pericardial sac with the needle that was covering by the blunt tip. And then later you could, once if you created the puncture, you could advance the guide wire using the anterior approaches. Also have been reported using the real-time pressure or the frequency monitoring. Once if you have moved to the pericardial space, you will have the pericardial signals. However, if you have touched the right ventricle, the myocardium too deep, then it will create the higher pressure signals, highlighted that we need to drop at the caster a little bit. With the video, so this is also another using the video scope. You could appreciate that the epicardial space with the coronary vessels, and then you could have the adequate assessment of the epicardial space. So the final novel one is the safer maneuver with the image guidance, and you try to compress the abdomen, and also try to illustrate using the lateral views and have puncture suppose. In this study, they also found a safer epicardial approach was associated with the less pericardial effusion and also less chance to have the need of the surgical interventions. So when we do the epicardial puncture, we still need to consider about such as the delay effect, the micro RV puncture, the delay effect of the coagulants, and also damage the adhesions if the patient have, and also the wrong sheath manipulation, which could create the damage of the coronary vessels and also the stem pop. Before doing the epicardial ablation, we need to understand the course of the Fresnel nerve, try to prevent doing ablation and also created the Fresnel nerve injuries. So several ways have been published in our lab. We most use the large diameter balloons to cover the ablation tip, try to prevent the Fresnel nerve once, especially for the non-ischemic heart, we need to do in ablation surrounding the lateral left ventricle. So sometimes we also need to prevent the coronary vessel injuries, especially doing the VT ablations. So the most important thing is traditionally we did not recommend to do the radio frequency ablation once it has the 1 centimeter close to the coronary vessels. So, ladies and gentlemen, here is my conclusion that the epicardial ablation is reasonably safe, but if you need to do about the possible complications, selected certain patients that need the epicardial approaches. And before, we need to have the very good preparation before doing a successful epicardial procedures and understand about which kind of material that we could have, try to improve the outcome. And before doing the epicardial ablation, we also need to prevent the friendly nerve injury and coronary vessel injuries. Thank you very much for your listening.
Thank you, Dr. Chung. Are you available online?
Dr. Chung? No, this is one of the centers. All the VTs get referred to this VT ablation center. There are a couple of minor changes. If we target the left shoulder, the chances of hitting inferior epigastric artery is little high. I mean, superior epigastric artery is quite high. Rectus sheath hematomas. So you try to remain a little more, not the left shoulder, somewhere in the mid clavicle. If you direct, you are more likely to be in the correct plane, avoiding this. Second thing is, if you look at it, we all get away, but if you start imaging, a lot of them have hepatic hematomas in the liver. We are able to get away in this country because most of our patients are lean. When you have an obese patient and we need to reach that surface, the chances of hematomas are higher. In fact, we started doing CTs to kind of register the images. Contrary to expiration, when we take a deep inspiration and press, the liver, everything goes down, and you get better space to enter. So, in fact, Muthaiya did this, and you can see some of the colonic gas, everything goes down the moment the patient takes a deep breath. So, these are the small things to avoid.
We had an obese patient whom we took a liver biopsy needle to get in, and yet couldn't get in. And then I had to call the surgeon to make a small nick and go out to the pericardium. And it was very difficult. He was 120 kg weight, incessant non-ischemic breathing.
So, sir, what are your ablation power settings typically for an epicardial?
Again, this is something which I wanted to say. 1 centimeter, we had a catastrophic complication once. It's not because we thought we were safe from the coronary artery more than a centimeter, but there was a steam pop in the pericardium, and this barotrauma caused an acute spasm of the coronary. Patient had a hypotension and other things. When we checked, it was a coronary spasm. So when you're close to coronary, 1 centimeter is okay, but I watch the impedance very well. And one thing is, we have a lower threshold for using half normal saline there. And one of the things I find extremely useful is you check in a view and make sure your contact will be good even with a contact force. But the contact may be on the parietal pericardium. So you need to ensure that the contact is on the myocardium when you start delivering lesions.
Narasimhan, you want us to break for tea, or there's some lecture there? Mukund.
Dr. Mukund Prabhu would now be speaking on electrogram-based mapping.
Good evening all. We'll start by thanking for this opportunity, for this wonderful meeting. I'll make it brief. I'll straight away start in the topic. The topic is electrogram-based mapping of ventricular tachycardia. We'll first visit the familiar VT circuit, which have 3 critical components: the region of slow conduction, a zone of unidirectional block, and the exit site. And all of these occur in a spatial vicinity within the ischemic scar. And based on what is causing the activation and how it is timed, we get different electrograms in sinus rhythm at the time of induction or during VT. And we are allowed to know or define the circuit based on these characteristics. And the circuit have other elements like bystander loops or outer loops, inner loops, which we are not very much interested in ablation. So our task is to define the circuit, and the 4 pillars of VT ablation are activation mapping, entrainment mapping, pace mapping, and substrate mapping. All of these are used in a given case to variable extent, but none of these give a single answer or are perfect enough, and there are other features which over the time we have learned to look into, and most of them have their own limitations. So the electrogram based strategy helps to define the substrate with a physiological outlook during the VT, and this may include late potentials, so-called lava, which is another form of late activation or abnormal activation, and of late other things have come up like evoked potentials, decremental potentials, and time voltage domain analysis, temporal component analysis. Just a brief mention about late potential. We are using it for more than almost 15 years now, and they are typically defined as isolated potentials occurring after the QRS offset, and they imply late activation of local myocardium, and those areas represent potential isthmus. And however, not all late potentials are harbingers of VT, like for example bystander loops and all may be responsible for these late potentials, and many of the actual successful sites may not harbinger late potential during our mapping. These are the limitations, and around 2012 or 14, that Bordeaux group came up with the concept of LAVA, local abnormal ventricular activity, and it is defined as sharp, high-frequency ventricular potential, possibility of low amplitude that are distinct from far-field ventricular electrograms, and they can happen towards the end of QRS, within the QRS, or just after the QRS. And they are also indicative of late activation of pathological tissues. And more likely, these sort of tissues are involved in the reentrant circuit, and you may get a higher success rate targeting these areas of late potentials or lava potentials. However, they have high specificity, but low sensitivity and low positive predictive value. This is the case of non-ischemic scar VT, which we did when I was in Melbourne. This map shows the late potential map, which are targeted as blue dots. You can see extensive areas of late potentials within the scar. Whereas if you go and tag only the lava, we get a much lesser extent of distribution of the lava potential. And this panel C shows a map where we have marked all of them, fragmented signals, late potentials, as well as lava. And actual VT circuit determined by activation mapping and entrainment showed that the isthmus lies somewhere in that marked area, which is a very low voltage area, and which also showed late potential. So the extent of ablation can be reduced just by using the lava points rather than all late potentials. So this electrogram-based approach further tries to analyze characteristic features within the EGMs that may be representative of isthmus or exit or entry points, which we have more interest rather than all late potentials. So this makes it possible to have a better and precise understanding of the circuit and targeted and precise ablations rather than blanket homogenization or a geographic ablation targeting the entire scar. And this also has advantage of use of less pacing maneuvers or repeated pacing maneuvers, which may be a problem in unstable patients. So 3 features have been of recent interest. One is tissue branching, second is conduction velocity restitution, and wave curvature. These are physiological concepts which we understand during our VT circuit. And the protected channel or the isthmus of the circuit is the most crucial thing, and we know that less number of branches, more likely that the tissue will act as an isthmus. The ideal isthmus should have a relatively long protracted strand of myofiber with no branches and insulated from all interactions from the surrounding myocardium. What happens with branching is the branching can be at the isthmus or in the center part or towards the end. If you have towards end, you may have a VT with multiple morphologies. Whereas if it is in the middle point, such strands are less often to be the isthmus of the circuits. Why? We'll have a look in the coming slides. This is because this will result in fragmentation of the EGM. Whenever you have branching, you have discontinuous electrical propagation and heterogeneity of the fibers. Whereas in protected channels, they can have only few stages of voltages. They don't have branches. So the spectrum of range of voltage deviations will be very less when you have a fragmented signal, unlike branch channels. So how does this comes into clinical practice? This was published in 2016 by using a concept called entropy. It's not possibly practical in our EP lab without the special signal processing software to know about this entropy. But indeed, we can have clues based on the EGM itself regarding how this will form. So this is a diagram from the Sachin Nayar's paper. The A shows the branched electrograms. When you have branches, the wavefront goes into the branch and also get electrotonically conducted back to the branch. And with more and more branching, the possibility of dying out becomes more, as represented by these black dots. And when you analyze the signal using the entropy concept, you will get a very high entropy. High entropy means high variation in voltages. Whereas a single branch, a single strand without branches, has a very low entropy if you go by the signal analysis. In practice, in EP lab, high entropy signals appears like this, where you have fragmented signal with heterogeneous types of peaks. You have a very varied range of peaks, whereas low entropy signal, which is representative of a critical isthmus or a non-branched tissue, will have a regular or uniform peak and tuff. It's not about the voltages, it's the distribution of voltages within the peaks. So protected isthmuses are more likely to be forming up. The isthmus of the circuit can support multiple circuits and with different morphologies if they are branched at the ends, lower mean activation time and greater dispersion in activation times and low entropy. Whereas because these features are not there, branch channels are less likely to form as potential isthmuses. These are examples of so-called entropy, low entropy versus high entropy signals. We don't have a entropy measuring software. It's a dedicated software, so probably it's not for clinical use now. Bipolar electrogram properties likely to be representative of VT isthmus are late activation and narrow voltage distribution. This is probably the clue that we have to take when we look at the fragmented signals to identify potential channels, and this can be done either in sinus rhythm or a V-paced mapping. And low entropy electrogram does not imply low peak to peak voltage. It's just a measure of variation in the voltage within the individual spikes of the fragmented EGM. Moving on to the next concept, this involves that unidirectional conduction block, which is mandatory for re-entry to occur. Why this happens is whenever you pace at faster rate, the conduction velocity prolongs. This is called conduction velocity restitution. And more the prolongation is, more likelihood of conduction blocks to develop. And a critical delay is needed for re-entry to get triggered. So this deep mapping technique, dynamic slow, decremental evoked potential mapping technique aims to identify such regions within the scar which can cause re-entry, critical delay and re-entry. And how does it get reflected in the electrogram? It's a pictorial representation. So both of these are fragmented potentials. But once you give a premature impulse by an extrastimulus protocol, this lower, the deep EGM splits out and one component gets very late. And studies have shown that this component forms the isthmus of the circuit when the VT get induced. So any fragmented signal which is not having a decremental component is less likely to be an area of interest. So we need to identify within the scar the fragmented potentials and start doing this pacing maneuver where we give a premature extra stimulus and see how the electrogram component behaves. If it is getting a late component, then probably it's an area of interest and we need to target it for ablation. This has been clinically validated in this paper. This is the original work from the Canada group, and it has reasonable, it's a small study, but it has a very high success rate, targeting deep potentials alone. And this is a map example showing the voltage map on the left, again from the same paper. And this is a late potential map. You can see an extensive area shows late potential. And this is the activation map during VT. Sites marked 1 and 2 are showed by the EGMs respectively, corresponds to entry and isthmuses. And deep potentials can be elicited in the entry point as well as exit points by the pacing maneuvers during sinus rhythm. So that reduces the area or extent of ablation need to be made to get the VT non-inducible. The final concept is wavefront curvature. This is used to identify the exit points. So whenever a local excitatory current diverges into a large tissue area, like from isthmus to the exit and surrounding myocardium downstream, there is a zone of block, a functional source sink mismatch. And what happens to the conduction is the wavefront curves. In the central stream, you have a higher velocity, whereas in the lateral or edges, you have a lower velocity. So wavefronts tend to get convex. That's how figure of 8 re-entry happens. This concept is utilized to identify from the EGM where it is likely to get curved. This is the physiology of it, which probably is not very important. We just need to understand whenever we have a slowing and curvature of the EGM velocity, we have characteristic changes in the EGM from which we can recognize that. So this is what happens when you have an exit site versus post-exit site. The first panel shows a relatively clean electrogram, almost like a far field or a single component electrogram. Whereas when you have the electrode placed right at the exit, you get a very fragmented sort of electrogram that precedes the QRS. The original paper shows around 60 millisecond before the QRS. And that appearance is called the rooster head appearance, where you have a sharp initial signal followed by a fragmented bunch of electrograms and a far field signal. This represents the slowing of conduction and wavelet curvature. So if you are in a place where you are getting such a signal just preceding the QRS, most likely you are at the exit of the VT circuit. Again, this alone was used for mapping, and reasonable success rate was attained by using this EGM guidance. And they use something called temporal component analysis. Again, needs a customized software for analysis. But in our clinical lab, probably we can identify these changes by this signal morphology. Just from the same paper, that most of the successful sites identified as exits had a 60 millisecond preponderance before the QRS, and that roughly matched with the conventional stim to QRS intervals. This is an example from the same paper where they use a multipolar electrode catheter and you get a sequence of activation from spline A to H as seen in the signal. And if you carefully see this electrogram 1-7, that morphology of electrogram proceeds around 65 milliseconds and has that characteristic morphology, one sharp component followed by a far field component. And that matched to the exit site. This is the signal analysis actually done using the software, which we probably will not be available to us. That wavelet was decomposed and based on the timing of the initial versus the second one. It's called Shannon entropy again. They could identify potential isthmus, exit as well as entry. And how practical are these electrogram based approach? So some of these manuals are done in intrinsic rhythm, others in extrasemblance protocol, and yet another in ventricular tachycardia. They had very high sensitivity as well as specificity in clinical studies. However, they were all very much time consuming, and probably that will be the greatest limitation. So these are the pros and cons. Can be done in sinus rhythm or during induction or in VT, and can be done even when VT morphology is not available. And elements of circuit can be precisely confirmed, and targeted and limited ablation is the major advantage. The cons might be, we always need high density mapping to delineate this, and tested only in ischemic cardiomyopathy so far, where the concept should be applicable in every substrate, but not tested in other substrate as of now. And no data on durability of VT suppression. These papers are mostly in last 4 or 5 years, so long-term data is still lacking, and may need additional signal processing tools for to take off the subjectivity of the signal interpretation, and it is of course time consuming. These are the techniques that are used in the original papers: time and voltage domain mapping to identify the entropy and classify the fragmented signals as potential channels versus non-channels. And it needed a computer algorithm called EPAS developed in Adelaide. And deep potential probably can be done in usual mapping setting as in our lab. And that temporal component analysis also used a spectral analysis software and made the wavelet packets to analyze it, reducing its practical utility. So in conclusion, EGM-based approaches offer a functional assessment of the component of VT circuits, can improve the precision of ablation and targeting the circuit with lesser number of lesions. However, can be more time consuming and need additional software as of now. Thank you.
One of the important components is to change the wavefront of activation, which will unmask this much better. Usually, targets for ablation in an ischemic heart disease is not very difficult. We go there, we see late potentials, we see. The problem comes in non-ischemic cardiomyopathy where you don't know where to ablate, how to ablate, and other things. So there, some of these, especially deep mapping, becomes very useful, and inferring that there is a mid-myocardial substrate comes in, it's just the reverse of what you see the rooster head appearance. Because it's mid-myocardial isthmus, you'll find first the sharp and then the mid-diastole will be a blunted potential. And unipolar, bipolar discrepancy will tell you that you're going to have a tough VT to ablate and should have probably a bipolar strategy in this. Sometimes just changing the wavefront of activation may help in this.
So now that we no more use bipolar for substrate or lavas because of its time-consuming nature, we use a multipolar catheter. Deep is very easy to do now. You have multiple signals there. Just give one extra, see which one has decremented, and put a dot on those lines. So it's much easier to do now than what it was earlier. Thank you very much for a wonderful talk. Really enjoyed it.
Thank you, sir.
You come in. We'll have a tea break just for 10 minutes and then we'll reassemble for the next session.
The Cobalt and Chrome portfolio was developed because we wanted to drive innovation forward.
A lot of these features have been in development for many years, and we're now bringing those to our customers for the first time.
Cobalt and Chrome bring an entirely new battery technology to the market.
40 joules delivered energy right from the very first shock and extended longevity.
The Cobalt and Chrome portfolio will be the first to showcase our intrinsic anti-tachycardia pacing algorithm.
We've done a great job reducing inappropriate shocks. We thought there was more opportunity to reduce unnecessary shocks, and IATP will help us do that.
IATP is a dynamic and self-learning algorithm that really looks at addressing why did ventricular ATP fail, and then tailoring or customizing that approach for each and every episode on each and every patient.
It's taking a look at each of these individual arrhythmias, figuring out how fast they're going and how far they are, and adjusting the pacing pulses and how frequent these pacing pulses should be delivered to maximize the likelihood that the arrhythmia will be terminated.
Managing heart failure in device patients is a really big challenge. A lot of these patients will go on to heart failure admissions, and there's really no great way of identifying those. That's frustrating for the patient, and it's expensive for the healthcare system.
So in the Cobalt and Chrome portfolio, this is the first time we will be showcasing the Triage HF feature. By using some of the metrics that the devices are already collecting, we're able to incorporate this into an algorithm and give them a predictive model.
Triage HF provides information to physicians in a more streamlined manner, helping them direct their care to those patients who need it most.
Triage makes the process simple and automatic for our customers.
Cobalt and Chrome have reimagined connectivity, bringing that BlueSync technology to the high-power portfolio.
By having MyCareLink Heart on the Cobalt and Chrome portfolio, the patients now have a direct link to their devices.
SmartSync, utilizing the tablet-based programmers, brings the patient and the clinician a lot closer together.
We're now able to speak to them, show them what we see on the programmer so that they are actively engaged in the process of taking care of themselves.
The future is here no matter where you are, in the lab, in the clinic, or in the patient's home. We listen to our customers, and we have delivered innovation to help the customers meet their needs.
Because this is not only innovation from a device perspective, but it's innovation in the way we deliver healthcare and maintain health for our patients.
The future is here, and we have a great opportunity in front of us with Cobalt and Chrome.
మళ్ళీ సైన్లో చేస్తే కష్టం. ఎప్పుడైనా నువ్వు బయటికి రావాలంటే శాలరీ తీసుకొని ఒకటి మనం బయటకు వచ్చేటప్పుడు శాలరీ అదే చిన్నది శాలరీ మన చేతిలోకి వచ్చిన
The Cobalt and Chrome portfolio was developed because we wanted to drive innovation forward.
A lot of these features have been in development for many years, and we're now bringing those to our customers for the first time.
Cobalt and Chrome bring an entirely new battery technology to the market.
40 joules delivered energy right from the very first shock and extended longevity.
The Cobalt and Chrome portfolio will be the first to showcase our intrinsic anti-tachycardia pacing algorithm.
We've done a great job reducing inappropriate shocks. We thought there was more opportunity to reduce unnecessary shocks, and IATP will help us do that.
IATP is a dynamic and self-learning algorithm that really looks at addressing why did ventricular ATP fail, and then tailoring or customizing that approach for each and every episode on each and every patient.
It's taking a look at each of these individual arrhythmias, figuring out how fast they're going and how far they are, and adjusting the pacing pulses and how frequent these pacing pulses should be delivered to maximize the likelihood that the arrhythmia will be terminated.
Managing heart failure in device patients is a really big challenge. A lot of these patients will go on to heart failure admissions, and there's really no great way of identifying those. That's frustrating for the patient, and it's expensive for the healthcare system.
So on the Cobalt and Chrome portfolio, this is the first time we will be showcasing the Triage HF feature. By using some of the metrics that the devices are already collecting, we're able to incorporate this into an algorithm and give them a predictive model.
Triage HF provides information to physicians in a more streamlined manner, helping them direct their care to those patients who need it most.
Triage makes the process simple and automatic for our customers.
Cobalt and Chrome have reimagined connectivity, bringing that BlueSync technology to the high-power portfolio.
By having MyCareLink Heart on the Cobalt and Chrome portfolio, the patients now have a direct link to their devices.
Gentlemen, you
SmartSync,
can
utilizing the
come in.
tablet-based programmers, brings
Start
the
the
patient
next
and the
session,
clinician a lot
Dalji.
closer together.
We're now able to speak to them,
May
show
we
them what we
request
see our programmer,
Dr. Darshan
so that they are
Jala, Dr.
actively
Hygrim,
engaged in the process of
and
taking care
Dr.
of
Anis
themselves.
to take over the
The future is here no matter
chair
where you
and,
are, in
conduct
the
the
lab,
session.
in the clinic, or in the patient's home. We listen to our customers.
Yeah, we'll start the second part of the session today. So there are two cases from the AIG team. Dr. Sachin will start the first case.
So, good evening, the respected teachers, seniors and friends. So let's have a look at one workflow track PVC which we did recently. It needs a different approach at times, so you have to change the way we look at. So let's look at she is about 39 years lady who had a recurrent palpitations, and she started developing recently a mild LV dysfunction, not very symptomatic of LV dysfunction, but she was very symptomatic of a PVCs. She was most of the time not palpitation. She was having a sinking sensation each time, and then look at the number of PVCs, and she will have each time such a feeling, especially in the early morning hours. So if you look at the PVC, it's relatively narrow. It's about 120 milliseconds, and then you see there is a R wave, blunted R wave in the lead V1 and early transition. Lead 1 and lead 1 shows AVL, both are tiny R and then the negative, and 2,3 is very tall. So it says that whenever we see such a PVC, So these are likely to be a little difficult PVCs, likely intramural also. So the first approach for this is we thought it will be from the one of those outflow tracts. We mapped the RVOT, nothing was early there. So then when we went to the left cusp, you see a tiny fractionated small signal here, although not very early, but nothing earlier than this we found earlier. So it's about 15 milliseconds earlier. And you don't get any unipolar for this, it's a tiny signal there. So then we mapped the pulmonary cusp. You see a sharp signal there and unipolar corresponds. But this is not very great signal for a pulmonary cusp. Pulmonary cusp, usually what happens, what we get is you get a potential, then there's an isoelectric line, and then you get a ventricular myocardium. If that is there, for sure you are on dot point and then you are sure it's going to go. But this is the earliest what we found after mapping. Thought we'll give a lesion here. We started ablating. So after about 20 seconds of ablation, it got suppressed. We're happy, but the problem is wattage was not reaching. This is a non-irrigated catheter. This is a reverse U-loop from the Biosense-Webster A-curve catheter, that's yellow curve catheter. Then we took a irrigated catheter around that region and we gave a prolonged lesion for about 25 watts. But after 3 minutes lesion also it is coming back. Then we thought, let us approach the intramural sites. Then we usually what we do is we do the wire mapping. BMW wire is quite good enough for us to use. We engaged the coronary sinus. Entering the coronary sinus was a little difficult, so we kept a we kept a guide at the AL2 guide at the os, and then we took over a micro catheter. We mapped here, and then we took a OTW balloon. We wire mapped this area. So I'll show you the LAO view next. So we wire mapped this area. This was a early signal about again 15 milliseconds. Nothing was better than this, so we decided to give an alcohol injection here. So this is the LAO view. You can see the only wire you can see we injected. Although it is occluded, there is some leak somewhere. We're not able to figure it out. We tried to figure it out. It was not possible. So in such a case, we figure out we usually go and occlude it with one more balloon so that there is no leak. It only reaches the intramyocardial site. So this site we chose because we have got a one side from the left aortic cusp and the left pulmonary cusp, and in between area we can map through one of these veins. So we enter this vein and so we gave alcohol. So the one best thing what happens with this one of these automatic PVCs is you get a little bit of automaticity and then it subsides. Although morphology may vary slightly, but it matches most of the times. So we gave and then we kept the alcohol there, staying the balloon inflated for a minute. We injected about 1.5 cc, but still after 2 minutes again it started coming back. We took another 1.5 cc injected and we held it for 5 minutes so that there's no washout. So after that there were no more PVCs. So this is a left aortic cusp and left pulmonary cusp. In between the area, it's likely that what we are missing. From the aortic cusp ablation, nothing happened. It was too far from there. So we entered this vein and then occluded and gave alcohol here. It got completely suppressed. After even follow up, 24 hours later also there are no more PVCs. Thank you.
Great. Just show the first slide once again, first ECG.
Yes, sir.
Very first ECG. See, what I can see, 2-3 AVF was positive and you had a transition somewhere in V2. The later on your transition was all V3, right?
That we ablated from after ablating from the pulmonary cusp, it changed a bit, sir.
That is okay. So that you started with this,
yes, sir.
Right?
Yes.
Okay.
Area which is early, usually in the left coronary cusp, but away from the coronary sinus. But did you have an image showing the vein going between the two, just two in the RVOT and
So the problem is that I didn't have a catheter in the the LCC by then. So we have only catheter in the, I'll show you 1 second. We left the hopes from the, we left hopes from the LCC, so we didn't keep anything on the arterial side. So we were mapping on the left cusp here. So this is the only catheter we have presently here in this region. This is only small injection. It was injection through the OTW balloon. You don't get a full injection here because it's 2 cc, very hard to inject.
Yeah.
So we didn't have any occlusion venograms because nothing was passing beyond microcatheter. So we had to take only wire and map that area.
So in this image, can you say where the catheters are located once again?
So these are, this is in the, both the catheters are in the pulmonary cusp actually. This is moved now, this is in the pulmonary cusp.
Pulmonary cusp.
Left pulmonary cusp.
Okay.
Yeah, this is under that. Just under that, if I have got a staining here, you can see here, we mapped it till here. Wire was still here at the tip, if you can able to appreciate that. So it completely got occluded, but there is some leak. We are not able to prevent that. So we injected here.
Okay.
Sir, you were saying something?
No, one word of caution. When people map the pulmonary cusp and ablate, please take up. Sometimes the left main runs just underneath the left cusp. Because we know of a case, it's not reported from the US. They started the burn, patient went into asystole. And it is a complete closure of the left main. So whenever you go to this area, more than aortic cusp, you need to take a left coronary injection to make sure the left main doesn't run under these cusps.
Right, that's electrogram from pulmonary cusp was also very good with a small spiky potential.
It's not, if you, yes sir, I do agree with you, but we get, if it is from there, you have a small spike, then isoelectric line and then that is definitely you are sure, but this was best available. Many a times we get away with it because it's just underneath. You can see the image here. If you see, this is just underneath the, sorry, this catheter have moved by now. Look at this catheter is just under here. It's suppressed in 20 seconds, but it kept on coming.
Great case.
Yeah.
Thank you, sir.
Thank you very much. Dr. Muttaya.
Hi, so I'll also be presenting a case of PVCs. The idea here is the mechanism of the PVCs and how the patient did. So this is a 16-year-old boy, was post VSD PFO closure with PTA all at a very young age. Normal LV function, had paroxysmal palpitations. These episodes were very typical, and every time it would last for 15 to 20 minutes, and every time it was usually triggered after a full meal. And he had previously undergone 2 RFA procedures.
My God.
So this is baseline ECG. Again, this is a patient, 16-year-old boy who is post TOF surgery. So sinus rhythm, right bundle branch pattern, QRS is around 120 to 130 milliseconds. So when we took him for procedure, these PVCs would always occur in a sort of in threes. So the first beat, we can make out that this is a sinus beat, and then we would have 2 subsequent beats, and every time they would come at a fixed coupling interval. So since it was a fixed coupling interval, our idea was that this would be a re-entry sort of mechanism that this PVC that was following, and the idea was to understand the mechanism of this second and this third beat. So you have and I'll show you the activation of the catheters, but you have His recording in distal and proximal, and these are the 3 beats that are occurring. So here you can see that the sinus beat, AH is 67, HV is 55, and then you see the PVC. The PVC is followed. So this third beat here is actually antegradally conducted with a long AH interval. The AH is 111 milliseconds, HV is 61, and this is the antegradally conducted beat here. So our idea is this is the PVC that we are looking at. And you can see that, and following this triplet, the beat is again conducted similarly to this first beat here. So this is so our idea was looking at this PVC duration and also looking at the morphology of the PVCs. The PVCs are very similar to the sinus beat. The only difference is the R wave in lead 2 and lead 3 is slightly taller than the exit of the PVC, saying that it may be slightly more apical in terms of its exit. And what you see here is, and you can see the catheters. There's a catheter that is now sort of, it's recording at the basal level, it's recording the His, and then you're also recording the posterior vesicle here. So this is the LV from proximal to distal, and these are the vesicular signals that are being activated. At this position of the catheter, these vesicle signals are proximal to distal. Again, this is during the sinus beat. So this is what is happening during these PVCs. So this catheter is now recording the posterior vesicular area. And what you can see here is this is sinus, the second beat is your PVC, and these PVCs are being, the posterior vesicle is being, the activation is distal to proximal. That is, you can see the distal, I'm not sure if I can zoom this one second. So this signal is the earliest signal, and you're seeing that there's a distal to proximal activation of the posterior vesicle. So this was the activation on the posterior vesicle. Now, simultaneously, if you look, if the catheter was placed in the anterior vesicular area, same PVC occurs, and during the anterior vesicular, there is clear activation from proximal to distal. So this PVC is being activated distal to proximal on the posterior vesicle and proximal to distal on the anterior vesicle. Now, if you put both these are, and I'll show you the simultaneous recording, but if you put these together, the anterior vesicle is being activated proximal to distal, and you can see that the ventricle is being activated distal to proximal. The posterior vesicle is being activated distal to proximal. So what are the possibilities for mechanisms of this PVC? One is that there is a re-entry between the posterior and anterior vesicle, distal to proximal on the posterior vesicle and anterior distal on the posterior vesicle. The other possibility is there's a breakout in the posterior vesicle, and rather than being a re-entry, there is a passive activation of the anterior vesicle. Now, if it was a re-entry, and then let me just sort of justify why we feel the mechanism is what it is. So here you see the simultaneous recordings of anterior and posterior vesicle. We can see that there is sort of a chevron pattern in terms of the ventricular activation on the posterior vesicle. So it's earliest here in the mid segment, and it breaks out both proximally and distally. Then the green recordings represent the anterior vesicle, which is being activated proximal to distal. So this cannot be a re-entry around the anterior and posterior vesicle because of this one, because of the chevron pattern and the way the anterior vesicle is activating. So it's there's a breakout here, there's breakout with activation on both sides of the posterior vesicle with passive activation of the anterior vesicle from proximal to distal. So the idea here was to target this breakout site on the posterior vesicle. This is the signal on the ablation catheter. It was an early signal. And pace map at this site, you can see the pace map here that it's while the pace map is being done. And it's a 12 by 12 pace map. Again, you can see the small difference between the sinus complex and the pace mapping site. So ablation at this proximal posterior vesicle, it led to what's the difference in the ECG here is if you look at lead 2-3 AVF, after ablation was done, there was a development of a left posterior hemiblock after the ablation. So this is the post-ablation ECG. And the HV after ablation, you can remember HV in sinus was around 51. After ablation, the HV was 63 milliseconds after the ablation. So again, so this idea is it's breaking out on both sides of the posterior vesicle. Anterior vesicle is passively activated, and your V is being activated from both sides. So the site of earliest vesicular activation was in the mid posterior vesicle. So this mechanism of PVC was a re-entry between the posterior vesicle and the adjacent myocardium with passive activation of the left anterior vesicle. So I'll stop here. Thank you.
Very good case, Muthaya. Just one, if you showed that EGMs in the where you showed the anterior and posterior vesicle together.
Yes, one second.
The earliest activation in the posterior vesicle is almost as early as the anterior vesicle, right?
So I'll
during VPC, I think the next one.
I'm not able to zoom it, sir.
Yeah.
You can see that the yellow line is what is the earliest activation. So the anterior vesicle is being activated slightly later than the.
No, some of the green signals are also as early, right? I mean, if it is in the middle VPC, the middle is also a VPC beat, right?
I'm trying to figure out how to zoom this, sir. One second.
No, it's okay. Even if you don't zoom.
Maybe, yeah. But I feel it's slightly earlier than the yellow line. There's some time difference there, sir.
There was an interesting teaching round session I think published in Circulation regarding how to time these signals in vesicular VPCs. I was
you can see it here.
Part of that. Yeah.
So this is the earliest signal here, and this is the earliest anterior vesicle. That is some time difference.
Somewhat earlier, right? Okay. Yeah.
Did you attempt to induce VT?
So these were only occurring as PVCs, sir. So there was never really a sustained, and that was one of that we could never really entrain, or that was one of the reasons why we couldn't really say it was an intervesicular re-entry, and that's why we had to go with the activation pattern.
Okay, sir. Can I ask a question, sir? Muthai, can you show the ECG? So if we look at the ECG, I was wondering. Were they PVCs or they are PSCs with a little more aberrancy? Means how sure you were before taking up in the lab that they were really PVCs and they are not just PSCs with aberrancy? And had it been in your thought that these are PSCs, then we generally do not attempt ablation for PSCs and we might try on medication. So how was your thought on that? I don't know whether my question is valid or not.
So one thing is he was quite symptomatic. So even if this was a PAC, even with the symptoms, but you can see that there's a clear sort of, there's a clear P wave in front of this QRS, and there is no such, and I can show you the intracardiac. I mean, sir's question is before we took up for ablation. So there's no clear P wave here before this complex. So
there are two things. Already 2 times he was attempted for ablation. That is sure shot that he has a PVC for sure.
Yeah, once you are in EP.
That's one. The clue was already there, and it's difficult, as you said. The PACs, if you can make out P waves, is very hard there. It's really difficult. And then the next beat is conducted retrograde. PAC conducts. So that beat looks similar.
If you go to the next slide, Muthaya, there you had a retrograde A which is conducting back as antigrade. AH with a long AH.
Yes.
So which means there should be a dual pathway physiology. Go up through fast pathway, come down through slow pathway. That can also be.
And the morphology of this A is slightly different than this A, sir.
Anyway, great.
I would like to ask one question. So did you get a Holter first? So
Holter
in that Holter, how was the coupling interval behaving with different sinus rates of the PVC? So
I'm not sure,
at
sir.
slower sinus rates, irrespective of the sinus rate.
Thank you. For want of time, we'll go to the next.
Actually, not for the CP crowd, but I have to mention this. If you see PVCs like this, for a general physicians, Dr. Narasimhan's question would be whether what drug the patient is on. The patient is on digoxin.
So next we will call upon Dr. Auras, also from AIG, to present on VT ablation with MCS.
Thank you, everyone. Just get the slides up here. So this talk is going to be a little segue. So far, we've been, looking at VT ablation from an electrogram standpoint, activation, entrainment. This is a little bit of an adjunct. It's how to get through your ablation safely as we take up more, a sicker population to the lab, both with ischemic and non-ischemic. With improved technologies, we have greater predilection to be taking these non-ischemics as well. So I'll try and finish this up in 12 minutes. So VT ablation with MCS is the topic given to me, and this is about preventing hemodynamic collapse. These are my disclosures. 3 learning objectives. One is to identify VT ablation patients who are at risk of hemodynamic compromise. Second, we'll briefly speak about the mechanical circulatory support options for these high-risk VT patients. And third is to evaluate the evidence, which, as you all know, is observational, so I won't spend too much time on that. So when we look at VT ablation patients at risk of hemodynamic compromise, and you look at the 3 components of patients, it's effectively, we are talking about patients with structural heart disease, those with ischemic and non-ischemic cardiomyopathy. And a lot of this work has come from Dr. Santangeli from when he was at the Penn group. And this paper in 2015 was really important in delineating the problem. And the problem is, what is the incidence rate of acute hemodynamic decompensation, AHD, as referred in this section of the literature, during catheter ablation for scar-related VT? This scar could be either ischemic, usually about 60%, or non-ischemic in all comers at the Penn EP group. So in this study, if you look, periprocedural acute hemodynamic collapse occurred in 11% of patients. And there were 8 clinical factors that were identified in their multivariable regression model. And this is the genesis of the pain ESD score, which is very important when you're assessing these patients. So the first one is COPD, which is pulmonary disease, P. And then advanced age, above 60 is what they used. Ischemic cardiomyopathy, heart failure status of NYHA class 3 or 4, EF less than 25%, and clinical presentation with VT storm, use of general anesthesia, and diabetes. And then in the 11% of patients who experienced hemodynamic collapse, you see that the mortality is 50% over a 21-month period as opposed to 11% mortality in the other group. So this was then generated into the pain ESD score again, and the way the numbering for each of these factors was produced was very simple. It was just the odds ratio in that multivariable regression model rounded off. So P is pulmonary disease or COPD, that gets 5 points. Age above 60 gets 3. Ischemic cardiomyopathy gets 6. NYHA class 3 or 4 gets 6 points. Ejection fraction less than 25% gets 3. Presentation with VT storm gets 5 points. Diabetes gives you 3 points. And then based on additional studies which I will show, it is identified that a pain ESD score greater than 15 is high risk. So if you divide these scores up, those with pain ESD score more than 15, they had approximately 24% mortality out of that 11% if you differentiate it. And those with a score less than 8, the mortality rate is only 1%. And then this we already mentioned that in those people who experience hemodynamic collapse in the lab, there's a 50% mortality in the subsequent year or two. And majority of this mortality is actually in the hospital. They don't even make it out of the hospital. And when we talk about AHD, hemodynamic collapse, it's cardiogenic shock, VT arrest, electromechanical dissociation, requirement of CPR, or a rescue LVAD, rescue percutaneous LVAD such as an impeller or an ECMO. So further studies used to retrospectively validate, and I won't spend too much time on this score were done both by the Penn group itself, which is Daniel Muser and colleagues, with Dr. Santangeli as a senior colleague, and Dr. Mathuria and group at Baylor St. Luke's in Houston. If you look at this slide on the right side, this was a 2017 paper. I think the takeaway here is that This was a retrospective study where they looked at patients who got a rescue ECMO or Impella because the patient collapsed in the lab, or then I think later in their experience, they started implanting these prophylactically based on their risk profile. This was before the pain ESD score was generated. And in the group that got the prophylactic percutaneous LVAD, there was a reason why they got it. That was because their pain ESD score was high. And this was comparable to the rescue group. Their pain ESD score was similar. Just the fact that getting it upfront and prophylactically, the mortality at 30 days is 4%. When it's done as a rescue after collapse has happened, the mortality is close to 60%. So this clearly shows us that identifying these patients ahead of time and perhaps supporting them with some form of temporary mechanical circulatory support can get you through this procedure safely, especially when you're taking this extremely sick subset to the lab. And the internal validation of the Penn group compared prophylactic LVAD as a strategy in about 75 patients, and they compared it to a historical cohort that was propensity matched on the pain ESD score. And again, they see that the 30-day mortality is 18% versus 30%. So these are non-randomized data, but this is clearly showing you signal that you can identify who is at greater risk of collapse and who will benefit from some sort of support. This is validated in a later on a JACC paper that Santangeli and the rest wrote from. This is from the International VT Ablation Collaborative. This is just looking at early mortality. 2,000 odd patients, 12 sites, 53% were ischemic. Early mortality occurred in 5% of patients. And 25% of these 100 patients received this rescue MCS. And only 5% of the 1,900 patients who did not experience early mortality received rescue MCS. And again, the pain ESD score was validated. In the early mortality and the late mortality groups, their pain ESD score was above 15. So 15 is considered the cutoff. So we know how to estimate who is at risk of acute hemodynamic collapse. It's the pain ESD score. It's well validated now retrospectively. What are the things we can do before we take this patient to the lab? And we should be doing this whether or not we use mechanical circulatory support, if that is an option or not. This is without taking cost as a factor for these MCS devices. But it stands, it's very reasonable that you have to decongest them to the best of your abilities, using either diuretics or some sort of CRRT, using a Swan-Ganz catheter to measure the PA pressures, and direct therapies to get them as optimal and hemodynamically optimal for the procedure is important. Involving heart failure colleagues and the critical care is important. And this is that, and also getting a multidisciplinary sort of decision whether or not to do an MCS in these high pain ESD score patients. And during the procedure, you can have your cardiovascular anesthesia colleagues monitor cerebral oximetry, which is a very acute and sensitive marker of tissue hypoperfusion, because lactate is another marker you can measure, but it typically manifests an hour or so later. And intraprocedural imaging will help. Just before the pressures and the perfusion goes down, if you have ice, you may see some subtle decrease in the contractility of the myocardium itself. And then this is, these are all the markers that you can monitor during the procedure, which is cardiac power output if you're using a device, lactate, and the mixed venous O2 in addition to cerebral oximetry. So, and the strategies to avoid acute hemodynamic collapse in high-risk VT ablation, obviously, if you don't have the device, is you can try and you can go with an approach of upfront substrate ablation and not do repeated inductions, which is actually responsible for this hemodynamic compromise. So knowing that repeated inductions can be a problem, so a predominant substrate guided ablation can be utilized, and other speakers have talked about this. So predominantly it's either scar homogenization or dechanneling based on just electrograms or some sort of imaging, cardiac imaging that has given you information up front. These are all obviously all reasonable things to do. And this is a nice tailored protocol that was brought up. I think this is by Dr. Davila's group. I don't know if this reflects well, but yes, in the high pain ESD score patients in more than 15, one approach could be to not take a induction approach, do a predominantly substrate guided ablation, and then no VT induction is performed at the end of this, and only if there is recurrence, then in the second ablation, other techniques are used. The other approach is a selective approach, where you, for pain ESD score less than 15, but more than 8, you do predominant upfront substrate mapping, ablate, and then do a limited induction if there is no identifiable substrate. So if you have a non-ischemic patient, the substrate is not very clearly evident. You've got to look intramurally, you've got to look epicardially, and if you have imaging information, it's helpful. If you don't, and you may need a limited VT induction. So these are sort of the techniques you can use to perform the ablation without MCS. But the talk today that I have is the use of MCS, so I'll move to the second objective, which is to look at mechanical circulatory support. So what are the true benefits of MCS? It's maintenance. It's just straightforward. It's to help you get through that procedure without killing that patient. It's maintenance of adequate cardiac index and end organ perfusion, reduction of intracardiac filling pressures, preventing significant increases in pulmonary vasculature pressures and accumulation of pulmonary edema, reduction of LV wall stress, improving the myocardial mechanics, and maintaining coronary perfusion. So ischemics tend to have slower VTs, which would make us think that they would be more hemodynamically tolerated, but in addition to their poor EF, they also have coronary issues, which is why they tend to decompensate more. Even though the non-ischemic patients, their EF is low and their VTs are faster, but the adverse effects are more in ischemics, mainly because of this coronary perfusion issue. The risks of mechanical circulatory support, obviously vascular bleeding at the vascular site, limb ischemia when you're using large bore devices other than the IABP, systemic bleeding because you have to maintain anticoagulation during the procedure, regardless of whether in the RV or LV. Risk of cardiac perforation, if you look at a device like the Impella or the tandem heart, which actually enters the cardiac space. Catheter entrapment, I'll just show you a video of that. So I'm not talking much about the intra-aortic balloon pump. I think that doesn't provide much support, and you may use that upfront anyway. So when we talk about percutaneous LVADs, we're talking about an Impella, and for all practical purposes, if you're going to do it percutaneously, it's going to be a CP, which gives you about 3.5 to 4 liters of support, or a tandem heart or VA ECMO. Now, there's a huge difference in the sheath size. An Impella is going to be a 14 French sheath in the femoral artery or the axillary artery, whereas we don't typically use an Impella 5.5. This is a surgical device, unless they already have it for management of their heart failure. This would be implanted through the axillary artery through a graft. A 23 French device wouldn't go in directly percutaneously. Tandem heart and ECMO both would have arterial cannulae up to 19 French. And then venous cannulae up to 25 to 27 French even. And then I'll just show you pictures. So this is also going to affect, I'll finish up in a minute. This is also going to affect which route you take to enter the left ventricle. If you go Impella, it's a retroaortic device, so you have to do your transeptal up front, and you do the VT ablation transeptally. Tandem heart it's a large bore that's going transeptal, so you pretty much have to do your ablation retroaortic. With an ECMO, you could go either way. So this is just a case that I done last year with an Impella, a Pentaray. So you have a lot of things. An ICE catheter, an RV pacing catheter. But basically the benefit is even if you induce VT, let's see if I can play this video. You can map during VT, even short frames, you're not going to do an extensive map. If VT induces, you don't need to rush and terminate. And this kind of gives you an idea. This is actually mapping in the epicardium. This was a lamin mutation patient. This was a 5th epicardial VT. And then this is I'm not showing all the electrograms, but VT is running here. You'll see it on the CARTO screen, and then it terminates during ablation. So these are some of the benefits, especially when you're doing non-ischemics. You can spend a little more time in VT while doing this. The one thing you have to be careful of if you use a closed catheter or like a grid catheter and you're using an impella, the two can interact. You see that the grid catheter is looped on the impella, and then you've got to finagle it a little bit. And this was published as a case report, a similar case by Dr. Davila's group, where an Atrial was stuck on an impella pigtail. So you may consider using an open pentaray, octaray kind of device for this. And the VA ECMO, nothing's in the heart, so you can ablate either way. VA ECMO is probably the way to go if you have a patient in electrical storm who's, and you may have to do an ECMO upfront to just stabilize them. And then I'll conclude with this, just to say 2 slides to say that all our evidence for the use of mechanical circulatory support is observational. And so the data are everywhere. Some of them show massive mortality differences. Most of them show no differences in VT. This is, again, like I said, you still have to do the VT ablation with all the.
Go to the conclusion.
So basically, this is all observational data. I don't know if we will have randomized control trial data. Thank you. Happy to take any questions.
Thank you. Interesting talk, but unfortunately we are short of time.
Sure.
So we'll go to the next talk. Dr. Amit, easy on line? Amit Ora? Autonomic modulation. Sure. Abhishek will talk on use of ICD EGMs in planning for VT ablation. Abhishek.
Of my recording, hopefully. Good evening, everybody. It's indeed a privilege to be a part of this Ventricular Tachycardia Symposium. So my topic today is on autonomic modulation for ventricular tachycardia. And I think the link between the heart and the brain has been known for over 400 years when William Harvey first demonstrated the neural network within the heart and its connection with the central nervous system. However, there has been a resurgence of interest in this field because of the unmet needs in treating ventricular tachycardia and fibrillation and cardiac arrest, and also heart failure and atrial fibrillation. But I think the landmark article by Nadamini almost 2 decades ago in managing patients with electrical storm sets the tone for the last 2 decades in terms of sympathetic blockade that was achieved by them in controlling the ventricular tachycardia storm by using either stellate ganglion blockade or beta blockers. And subsequent to this, there has been a lot of research and interest in this field. So to understand the cardiac neuraxis, we need to recognize that there are 3 levels in which it works. The first is the intrinsic cardiac nervous system within the heart, the level 1. Then would be the extracardiac but intrathoracic nervous system, the stellate ganglia. And finally would be the central nervous system, which includes the spinal cord and the brain stem. And it would be important to realize that there is a constant back and forth between the heart and the brain. And in fact, the intrinsic cardiac nervous system is actually called the little brain in the heart. So there's a constant efferent signals going from the heart to the stellate ganglion and to the spinal cord and the brain stem, and then there is a bidirectionality in terms of the efferent influx coming to the heart from the brainstem, the spinal cord, and the stellate ganglion. So what happens in diseased state is that this fine sympathetic and vagal balance is lost, such that there is a sympathetic overexcitation and there is a parasympathetic withdrawal. And our aim in controlling arrhythmias, heart failure, is to have a resurgence of this balance in which we try to reduce the sympathetic overdrive and increase the parasympathetic activity. So this is what is done, and I'll kind of step back and try to clarify certain definitions, certain terminologies, because these are things which are used very frequently in day-to-day practice managing electrical storms. The first being stellate ganglion blockade. This is what Nandamini used. A 22 gauge needle under the USD guidance is directed towards the transverse process of C6, avoiding injury to the carotid artery, and a 1% xylocaine or bupivacaine without epinephrine is injected. Now, this stellate ganglion blockade by this injection means generally the effect will last for a few hours, 2 to 4 hours max. Now, to tide over the electrical storm with the repeated ventricular tachycardia and shocks required, we need sometimes longer period, and that's where thoracic epidural analgesia came into being, wherein a 17 gauge 2E needle inserted into T1 to T2 or T2 T3 epidural space, a 19 gauge epidural catheter is advanced 5 centimeter beyond the needle tip, and a bolus of 0.25% 1 ml bupivacaine is injected, followed by an infusion at 2 ml per hour and up titrated as per the blood pressure and the arrhythmia control. Now, this thoracic epidural analgesia also works for 3 to 4 days, but sometimes it happens that it works, but there are no obvious correctable factors for these arrhythmias, and they tend to recur. So to have a permanent solution for these temporary effects which have helped to quieten the arrhythmia storm, in some patients, we go to a complete autonomic denervation of the heart by doing a stellate ganglionectomy. This is a surgical resection of the stellate ganglion. The stellate ganglion is formed by the C8T1 nerves. So when we know that the C8T1 stellate ganglionectomy is done, often there are side effects in terms of Horner syndrome and anhidrosis and stuff like that. And therefore, it is realized that if you spare the C8 and only take the T1, so T1 to T4 sympathetic chain, if it is only taken care of, it controls the sympathetic drive onto the heart without having the complications associated with the C8 removal. So if you resect the lower 1/3 or half of the stellate ganglion, then along with the T2-4 sympathetic chain, it becomes a high thoracic or a cardiac sympathetic denervation. So this is what we label as cardiac sympathetic denervation, which is what is currently done. And you would see that the cardiac sympathetic denervation currently is performed by surgeons with a video-assisted thoracoscopy. It's a single lung anesthesia given, and you can nicely see the sympathetic chain. The C8T1, the lower half of it is resected, and from T1 to T4, and this is the resection which you see where you have the lower half of the stellate ganglion and T2, T4 chain is completely resected. We send it for histopathological examination, make sure that the right structure is removed. So doing this has helped to tide over many electrical storms. And I think in our experience, we have been using this for more than a decade. We collated the data of 7 years up to 2018, and subsequent, we must have done another 25, 30 odd. So nearly 100 number of cardiac sympathetic denervation for ventricular tachycardias. The average age of our patients is 50 years. Male preponderance, the ejection fraction is just about 25% or so. ICD is being implanted in vast majority of this patient, and so it's recurrent ICD shocks that get these cardiac sympathetic denervation. RF ablation in our center is used as a second choice often in electrical storm patients. So first, if suitable, then we go to cardiac sympathetic denervation and then only fall back to radiofrequency ablation. So the number is just 1/4 of the patients undergo radiofrequency ablation. We have a decent follow-up, and bilateral cardiac sympathetic denervation is the current norm. Earlier, left cardiac sympathetic denervation was done, and now bilateral is being done. Our the common indications is ischemic heart disease, but it could be also various forms of non-ischemic cardiomyopathy and infiltrative cardiomyopathy, sarcoid and tubercular being common. And of course, some of them are channelopathies in which we have considered. And long QT and CPVT are the commonest one, where only a left cardiac sympathetic denervation is done. The VT types which undergo cardiac sympathetic denervation in our center, a vast majority are multiple morphologies of monomorphic ventricular tachycardia, the pleomorphic VT, 40% being monomorphic, rapid monomorphic VT, which are hemodynamically unstable, multiple such episodes, and a small number being polymorphic VT-VF. And we have had a fairly decent result in terms of no VT recurrences occurring in almost 50% of the patients, VT successfully treated with ATP only after cardiac sympathetic denervation in good 10-11% of patients. But shock requirement comes down, but not negligible at 13%, and recurrence of VT storm occurring in 12% of patients. The complications are very few: sinus bradycardia, Horner syndrome, anhidrosis, pleural effusion, and only some of them are really sick, and there is a mortality also following this procedure. So overall, what in our center, what we do is in terms of cardiac sympathetic, I must thank Yash, because he's a driver in terms of leading this technique. So patients with recurrent ICD shocks and those who come in VT storm, and sometimes the long QT and CPVT patients, these are the patients whom we choose for cardiac sympathetic denervation. Now, if the first two category, the VTs are monomorphic VT and they are stable and slow VT, then we would go for radiofrequency ablation. However, if the VT is pleomorphic, unstable, rapid VT, non-ischemic cardiomyopathy, infiltrative VT, and in patients with channelopathies like long QT and CPVT, if there's syncope despite beta blockers, then we would go for cardiac sympathetic denervation. So this is the flow chart which we normally follow. And we find that cardiac sympathetic denervation benefits patients with recurrent ICD shocks and VT storm. It benefits patients with long QT syndrome and CPVT. It is effective for rapid monomorphic VT, pleomorphic and polymorphic VTs. And we urge that centers performing complex VT ablation receiving VT storm patients should have the capability to do video-assisted cardiac sympathetic denervation. So our surgeons should be trained in doing it. We have 3 surgeons doing it in our centers. In select patients, cardiac sympathetic denervation may be considered prior to VT ablation. That's not the global standard, but in our center, we tend to do sympathetic denervation earlier than RF ablation. But yes, that may be considered in some patients. Bilateral cardiac sympathetic denervation is considered the current way to go, and unilateral or left cardiac sympathetic alone is not done these days because of recurrence rates. So if you look at the cardiac neuraxis, then you realize that there are various targets which can be used to have the autonomic modulation to control the ventricular tachycardia. And in terms of pharmacological modulation, we know the beta blockers, but we also need to understand that there are recent investigations happening in terms of more advanced targets. So the NYP receptors are the ones which are being targeted. So nucleotide receptor Y is what is being targeted also in terms of drug development. Glial cell modulation is being targeted. We spoke about the cardiac sympathetic denervation and stellate ganglion blockade. This is some of sympathetic denervation happening. But to improve the vagal tone, the parasympathetic nervous system also needs to be activated. So you need to blunt the sympathetic tone, but activate the parasympathetic nervous system. Vagal nerve stimulation is being done. And what we also do is tragus nerve stimulation is being attempted. Now, the tragus nerve stimulation is to avoid the side effects of vagal nerve stimulation. Vagal nerve stimulation being more invasive, surgical approach is required, and it's being studied in atrial fibrillation post-bypass surgery. But tragus nerve stimulation can be done non-invasively, transcutaneous, and probably
Have we lost him?
Can you hear me?
Yeah, now there's a pause for some time.
No, so I think the recording probably has had a pause. So do you want me to share my screen?
Yes, please.
Okay, then I'll probably so we can see this?
So we can.
All right, okay. So we were talking of the newer targets for autonomic modulation and parasympathetic nervous system activation, one of the things. And similarly, the spinal cord stimulation, the cardiac control is being attempted to be achieved by these techniques. So I will just sum up what new is happening in this field by showing this table, wherein the conventional cardiac sympathetic denervation by the surgeon using video-assisted technique is being replaced by radio frequency ablation of the sympathetic chain. Cryothermal ablation is being used. And I think the exciting times would be with magnetic stimulation and ultrasound stimulation of the stellate ganglion, which is attempted to be achieved by transcutaneous means. So it will become non-invasive, and even it could be kind of on-demand use. So when the patient has the problem, he can activate these systems, and you could have a higher vagal tone and a blunted sympathetic response, which may help to quieten down their arrhythmia storms. And renal denervation, we know, has been tried, and there's a resurgence in hypertension. But similarly, it can work in, there have been 2 series where ventricular tractate ablation in adjunct to renal denervation has been done, and they found that there is a reduction in the VT recurrence rates. But there is a reinnervation known to happen with renal denervation. So some investigators are looking into aortic-renal ganglia ablation to take care of that. So in brief, there is a lot of individual case reports, small case series being done, but in terms of autonomic modulation, yet we do not have large randomized trials. And I think precisely one of the reasons being that we need to understand that what is the endpoint, to be able to know what should be the stimulation protocol and what should be our endpoint when we use this autonomic modulation tools is something which we need to kind of define very well before this becomes a standard technique. I think, but nonetheless, it's an exciting area which has a definite role and probably will be used more and more in the coming years. Thank you very much for your patient listening.
Thank you, Amit. Just one question. I was interested to see your 10-year data which you collected. Interestingly, a significant number is coronary artery disease. Just want to ask you, initial days, say 10 years back, things were different. Over the period of time, have your practice changed in terms of relegating CSG to a second when compared to ablation, when compared to 10 years back, or is it the same even now?
So it has changed. It has changed. So I would think that, for ischemic heart disease subset, the ablation is done much more frequently and as a first step, and only after the ablation, if there are recurrences and VT storms happening, then probably you would go to CSD, as opposed to the non-ischemic variety and especially the infiltrative myopathies. There, I think the threshold for doing the sympathetic denervation is much lower, and we probably do it earlier. So yes, I think well-defined scar and ablation is probably a more easier target. Endocardial ablation is the easier target. Epicardial ablation is something which we don't do very frequently, and therefore the non-ischemic varieties and the infiltrative varieties are the ones where we kind of subject them to CSD first and ablation as our last resort.
Thank you, Dr. Vora, for making a complex subject simple and explaining the basics of sympathectomy. But for want of time, I think we'll have to stop here and move on to the next one. Thank you.
Can we start the next presentation by Dr. Abhishek Deshmukh? He's online. So we'll be talking on using ICD EGMs for VT ablation. It's an important topic, yeah.
Yeah, thank you for the kind invitation. I sent a video.
My name is Abhishek Deshmukh, one of the electrophysiologists at Mayo Clinic, and I'm going to talk about role of ICD tracings in planning VT ablation. And the reason why sometimes this becomes important is that we don't always have access to the 12-lead ECG or telemetry strip as we are embarking on the VT ablation. So let's look at some opportunities and options from ICD tracings. So we can get information about the location of the lead, which we know from the X-ray. We can figure out some relative activation among the different leads which are present in the heart, use of far field and near field signals, response to ATP, and then finally we can compare some tracings during ablation. So as a start, whenever we look at an ICD tracing, we should know what kind of information we are getting. So we'll get a leadless ECG, we get a far field electrogram which is created because from the CAN to the RV coil. But sometimes if you have a dual coil lead, you can also get an electrogram between the CAN and the SVC coil. So important to know how this electrogram is getting created. You'll get a near field signal, which is between the RV tip and RV ring. And then you'll get marker channels to see what is the device actually seeing when it is making its interpretation and showing it to you. Now in the normal heart, you have a lead in the RV apex, a lead in the right atrial appendage. And when we look at this information and device tracings, we can clearly see that the far field signal on the atrial channel, which is the right ventricular signal, is later compared to the RV near field signal, which is RV tip to RV ring. And if you just look at the anatomy of the heart, the right atrial appendage is very close to the right ventricular outflow tract. So if you have a pacing lead in the right atrial appendage, the far field signal what you're getting is from the right ventricular outflow tract, and that can sometimes help to figure out the timing of the ventricular tachycardia. So in normal activation, the RV apex is going to get activated before the outflow tract. But if you have a VT coming from the outflow tract, then this signal would be earlier compared to the RV apical signal. So relative timing interval between the near field and the far field signals can help. Similarly, if you look at the heart in the LAO view, you have the RV coil, going here and the lead in the right atrial appendage. And the far field electrogram, which is created between the CAN to the RV coil, is kind of like a lead 3, a surrogate for lead 3. So if that's the case, if you have a VT which is exiting in the left ventricle As you have lead 3 morphology, the CAN2 RV coil, which is giving you some information of the left ventricular activation, would be earlier compared to the onset of the near field signal between RV tip to RV ring. So if that far field CAN2 RV coil is earlier, then you may think this VT is more likely coming from the left ventricle. A caveat to this is if you have VT coming from the free wall of the right ventricle, it may still hold same because the activation is away from the near field electrogram, and that's why that signal might be early, but the polarity of the CAN2 RV coil EGM might be different. So important to look at this aspect when we analyze these tracings. So let's start off with a case of a 52-year-old female. She had coronary artery disease, apical infarct, and recurrent VT. So right bundle morphology, negative in V4, V5, V6, negative in lead 2, starts off being negative in lead 1 and AVL. So kind of suggestive of more apical, inferior, and lateral exit for this VT. Now on device tracings, when we review this, you have an atrial, near field atrial signal, near field ventricular signal, and a shock electrogram which is between the CAN and the RV coil. Now here you will see that the RV near field signal is certainly earlier compared to the far field signal what you are getting from the outflow tract. However, the shock electrogram onset is earlier compared to the RV near field signal. So again, suggesting that this might be exiting from the left ventricle as we are looking at this tracing. The VT was mapped and ablated as we see from the apical inferior lateral location, and that was the exit, and then a significant substrate modification was performed. Now ATP, as we know, is helpful to pace terminate a lot of VTs. So you have a reentrant tachycardia going on, and you have a pacing wavefront which kind of collides with this wavefront. One wavefront is going orthodromic, one wavefront is going antidromic, and the antidromic wavefront, when it collides with the orthodromic wavefront, can cause termination of the ventricular tachycardia. However, this is great when the VT terminates. But the same principle what we use in the EP lab to look at ventricular overdrive pacing while looking at when we are trying to entrain tachycardia, the same principles we can use while analyzing anti-tachycardia pacing. So in this VT, as we were seeing, the far field signal was earlier compared to the near field signal, suggestive of LV exit, and the post-pacing interval was quite long, suggestive of that the source from where you are stimulating is further away from the VT circuit. And again, if you have a very lateral circuit, then the PPI is going to be quite long. So this is how you would analyze PPI, and see if the PPI is very long, then that would be suggestive that the circuit or the exit is further away from the site of stimulation. Now, few other places where analysis of these far field electrograms become important is also to analyze fusion. So you have a VT going on here, and you can see that the near field here is little bit earlier than the far field EGM on the atrial channel. So suggesting that this is definitely not a VT exiting from the outflow tract. We don't have a far field EGM here, mind well. Then we do anti-tachycardia pacing, and you can see the polarity of this signal becomes completely different compared to what it was in VT. Again, suggestive you have some manifest fusion going on. And these things sometimes can also help if the PPI is looking good, or we have a PPI minus TCL, which is a short one. Now in this example, as you again see, the PPI minus TCL is very long, 740 milliseconds. So again, you're further away from the circuit. And again, this was kind of an inferolateral scar which was mapped and ablated from where the VT was exiting from. And these clues can sometimes be helpful. However, now let's look at another example. You have VT going on. This patient actually had LVAD and recurrent episodes of ventricular tachycardia. Now look at the shock EGM. is little bit earlier compared to the near field signal, may suggest LV exit. And then when you have antitachycardia pacing, the overall polarity of the shock EGM and the pacing EGM on the shock electrogram is somewhat of the same polarity. Now here, the post-pacing interval is not bad. It's long, but not too long compared to some of the examples what I had shown earlier. So when you have this, so you know that the VT exit might be closer to the site of stimulation from this, from the site of stimulation of this RV electrode or lead. Now, during the procedure, the patient actually had bundle branch reentrant VT. So the left bundle branch block morphology. So VT exiting from the right bundle and then transeptal conduction going up the left bundle again. And now if you think about it, the RV lead is at the apex. So it is closer to the exit of the VT. And that was potentially the reason why the PPI was little bit shorter here compared to some of the other examples what we had seen. You may wonder why the far field EGM here is earlier compared to the near field EGM. Would it mean that the VT exit is from the left side? It's tough to know, but again in LVAD the apex is completely out and you have a cannula there, so that may also shift some of these vectors. Now, lead location and site of stimulation becomes important. Now, this patient, as you see, has a dual coil ICD lead which is abandoned, and now has a single coil ICD lead which is a little bit more anterior and more septal compared to the existing dual coil ICD lead. Patient was having recurrent ventricular tachycardia. This is the response for antitachycardia pacing. And lo behold, the PPI is 370 milliseconds and tachycardia cycle length is 350 milliseconds. So PPI minus TCL is 20 milliseconds. So we are really close from where we are stimulating the site of the VT or the isthmus of the VT. But have we captured? Because all these signals are saturated because of amplifier saturation. Well, then again, some of these far field EGMs can be helpful, because on the atrial channel, you get these far field EGMs which appear to be accelerated to the pacing rate. And when you stop pacing, these far field EGM are at the rate of VT. So you have definitely accelerated the VT with this pacing maneuver. And then when you stop pacing, the PPI minus TCL is about 20 milliseconds, suggesting you are very close to the circuit. Now, if you remember, the lead was more anterior and more septal. So the VT circuit exit should be somewhere very close to that. And it was actually an anteroseptal VT, what we mapped and ablated in a patient with hypertrophic cardiomyopathy. So again, the exit of the VT was very close to where the lead was present for ATP, and that would be a clue that where the exit of the VT is going to be. Now, how about polarity of the far field EGM? So as we know, whenever an activation is going towards an electrode, it makes a positive wave. Activation going away from the electrode, it's making a negative wave. So generally, if your far field CAN to RV coil EGM is negative, then it is going to be more inferior exit. And if the CAN to RV coil is more positive, that's going to be a more anterior exit of this VT. And then the timing of the far field EGM and the near field EGM will also be helpful. So here, as you see, they are almost on time, suggesting that there is no time, there is not a big time difference between the near field and the far field. So it might be kind of close to where the ICD lead is, maybe on the septum, but maybe more anterior exit. And that's how you can help to sort these things out. How about if you have a clinical VT which looks like this, you don't have a 12-lead ECG, you bring the patient to the lab, and generally here at Mayo, we would keep the device interrogation going on continuously as we induce VT, and we look at all the various far field EGMs as the VT is getting induced. But none of these looks similar to the clinical VT what we induce. So you will see a lot of multiple inducible VTs in the case. So really how to know the clinical VT? You can certainly pace map and see if you can find a site which is similar to the clinical VT far field EGM and the pace map far field EGM, and sometimes that can help to sort it out. Certainly not perfect, but another approach what you can use during your ablation cases. Now, does everybody who gets anti-tachycardia pacing, do they have VT? So let's see this example. You have a tachycardia going on. A patient has a CRTD in place, recurrent episodes of palpitations, pre-syncope, and episodes of VT. And you have this tachycardia. You have ATP. So what is the most likely diagnosis? VT, ORT, AV-NRT, or atrial tachycardia? So let's go back to this tracing. So this tachycardia is, you have A-sense LV pacing going on. PAC initiates a tachycardia. It's a 1-to-1 tachycardia. The morphology of the shock EGM is similar to the morphology in normal rhythm, or I should say with paced rhythm. And then you have initiation of anti-tachycardia pacing. This is the first beat, which appears fused between the tachycardia and the paced beat. The tachycardia terminates in the atrium with the first beat, fused beat. This is pacing again, and you have resumption of normal rhythm again. So first paced beat fuses and terminates the tachycardia in the atrium. This is almost similar to like a His synchronous PVC. If you time it, you can block the activation to the A, suggestive of an orthodromic reentrant tachycardia. So sometimes these tracings can be helpful to sort these things out. It can also be helpful that you have a patient coming for an ablation with recurrent shocks. Important to also see how the VT is initiated. So in this patient, this was clearly initiated with a short sequence, and really no amount of ablation is going to help this patient except for atrial pacing, and that's what we did in this patient, and he did fine. So in conclusion, location of the lead becomes important, and it's important to know what is the far field EGM. The relative timing of all the data what you have, the far field, the near field, and the far field EGM of the ventricle on the atrial lead, all these things can help to know the activation in the heart, and that can help to sort out the exit of the VT. The far field morphology is also helpful because if it is CAN to RV coil, that would be a surrogate of lead 3, and that can sort of tell you whether it is an anterior exit or an inferior exit. Response to anti-tachycardia pacing is important because the far field EGM will tell you whether you have actually captured and accelerated the VT, and the post-pacing interval, which is although noted in time, is really the distance from where you are pacing and where the VT isthmus is going to be. So that can sort of tell you where the exit of the VT is. And finally, during ablation, comparing the various VTs and their far field EGMs during the lab to the far field EGMs what you have recorded on the patient as he's getting VT therapies, in the at home or in the clinic, will be important to sort out if you have mapping the clinical VT. And that would help in comparison. So I think I'll stop here, and thanks a lot for your patient hearing. I'll be available for questions. Thank you.
Brilliant talk, because when you nicely shown, how many ways you can use the ICD electrograms. Is a very good teaching point. Now, one question is practically. These are very good intellectual exercises, but in your practice, practically, where is it that you found any specific situations that it had an incremental benefit when you took a patient for ablation?
No, thank you for that question. I hope I'm audible. I think it is, you will be surprised to, and practically in every case what we do, it matters a lot. Looking at the relative timing of the far field atrial EGM and RV signal, LV signal, if you have a CRT device in place, response to anti-tachycardia pacing, polarity of the far field EGM, all those things help a lot when we are mapping. And most important thing is to know where is the RV lead located. Because if you know, as I showed you in the example with hypertrophic cardiomyopathy, as the lead was more anterior and septal, that was basically diagnostic where the circuit is going to be as the PPI was so short. So I think it helps a lot that if we can analyze these things very systematically, we can gain a lot of information.
One practical question, if when the VT is not easily inducible or when it is not stable, whether you can do pace mapping on the geometry and try to match the QRS complex with these multiple morphologies?
Yes. No, great question. So if the VT is not clinically inducible but you have a baseline far field morphology of the VT recorded, then you can certainly do pace mapping to have a general idea, where you are. If the polarity is completely opposite, you're in the wrong part of the heart. But if the polarity is similar to what you have seen on the far field EGM, and the timing between the far field EGM and near field EGM is similar to what you're getting with pace mapping, at least you have a ballpark idea that you're in the right area where you can do more detailed mapping and all that.
Any other questions, or we can go to the next talk? So we'll proceed to the next talk. Thank you, Dr. Deshmukh. Excellent presentation. So I invite Dr. Balbir Singh, sir, to present on complications during VT ablation.
To avoid complications.
So my talk is preventing complications during VT ablation. I thank Dr. Narasimhan for having me here. And let's see that now VT ablation has become a standard of practice, and we know that you do better than escalated drugs. And meta-analysis shows that there can be a mortality benefit. So VT ablation is there to stay, and we have to be very, very sure how to do it and how to get rid of the complications. So let's go back in time, 2009 VT ablation guidelines. They did not think that complications are high enough to warrant many recommendations on what should be done and how it should be done. They just mentioned one line, that careful attention to the fluid balance. So 2009 guidelines were quiet on VT ablation. But as the procedures grew, we certainly realized that it is not that true. VT complications are high. So let's look at major complications from a single center 2009 publication. Structural heart disease with idiopathic VT. So idiopathic VT tends to have lower complications. Let's look at the complications. Tamponade, thromboembolic events, which could be stroke or TIAs, conduction system damage, RV dysfunction or CPR during the procedure. You can see two patients here. Vascular excess complications. They divided these complications and tried to predict who are the worst of these complications. And you would see high risk operator tends to have the highest risk of a problem. And this is something to be understood. That means we need to learn. And then you come to serum creatinine levels, then you come to LV function, you come to LV volumes. All these contribute to complications. Then we come, at that time, mortality was not realized. But then came this study again in 2008, comparing the multi-center thermocool ventricular tachycardia ablation trial, 3% hospital mortality, which is huge. And mortality happened in 4 patients within the lab. And this is such a disaster, the whole system gets upset and it's a disaster to happen. And there were many non-fatal complications. So how do we mitigate some of the risk? One is to do a good pre-procedure risk assessment. When the patient is in the lab, you know these are huge risk factors. Always take an ABG before we put in any catheter. A lactate more than 2.2 should ring a bell. Low cardiac index and low blood pressure to start with is again a problem. Vascular complications are completely avoidable, should not happen. In our lab, all patients, all punctures are done with ultrasound guidance. No puncture in the femoral artery or the vein is done without. Even in AV artery ablation, the venous puncture is with ultrasound guidance. Any sheath on the artery site, 7 or more, is closed with a close or an angioseal. The patient won't go out of the lab without a device closure. So let's look at the possible complications. Vascular can be avoidable. Tamponade is another avoidable complication, and death. So this was one of the initial scores which was published, and this is called RIVA score, and it was reassessed, which was age more than 60 gets 5 points, NYHA class 3 or more 5 points, structural heart disease gets 6 points, epicardial puncture straight away gets 14 points, and some of the reasons why epicardial puncture and complications are higher we know. Low GFR would continue to be one of the major risk factors. So as the number grows, the estimated complication rate goes up. So preventing stroke with VT ablation, first is the access. We should try to get as many procedures done across the septum than the aorta. Many of these patients who have atherosclerotic coronary disease have very bad aortas. You look at this ugly aorta and the dissection that it caused with the catheter. So using a long sheath, if you're using an aorta, just fluoroscope the aorta. A lot of calcium is seen. Try to avoid that. And then even if you have a long sheath and having problems to go through the retrograde route, it's a clear indication that probably this is the safer route. This is the sheath here and this is the catheter here. This sheath can lie in the left atrium and you can monitor the pressure. So you just attach an Agilis sheath, you attach a three-way, one part goes to the flush and one part to the continuous LA pressure monitoring, which helps a lot during the procedure. Because sometimes the LA pressure is extremely low and the hypotension is because of low LA pressures because patient hasn't eaten and there's been no fluids. So this is a very important aspect. Vascular access as far as possible septal. There has been some talk of use of Sentinel to protect the carotids. I haven't done it. It's a costly thing. This is a patient who has an LV thrombus, and with LV thrombus they did an ablation. And you can see the debris which was collected from this carotids by using a Sentinel device. Of course, this will add a lot of cost to the procedure and is easy to do from the right radial artery, but even in TAVR it has not produced great benefits. But this is very important, which I started in my practice and realized how important it is. This is the stroke VT trial by Laika Reddy, which is published in 2021. So they had a study population of LV ventricular ablations, 246 patients, randomized between DOAC and aspirin. So direct anticoagulant or aspirin was started 3 hours after having hemodynamic, after having the vascular closure or no bleeding. And then they compared looking at the clinical events, which was stroke or TIA. So the TIA was reduced remarkably. Strokes were 0 in the DOAC group. And then they did an MRI at 24 hours and 30 days. And clearly there was a huge difference between a DOAC and use, and we do it routinely now. I have started using it. We had 2 patients who had minor strokes 48 hours after ablation. And I remember it was really a disaster to do a good VT ablation and have a stroke 48 hours later. Long ablation time, retrograde excess. So septal excess has lower stroke complications. Lower EF and aspirin use were the adverse factors. So DOAC reduces significantly the risk of stroke, TIA, and asymptomatic embolization. We just heard a beautiful lecture on hemodynamic instability. There are a lot of issues with it. First issue is that we now have less VT inductions, we have less entrainment mapping, we have, even if the patient has a stable VT, the so-called stable VT, doing long entrainment maps, mapping the VT circuits, trying to discern the isthmus, exit and entry can sometimes be very compromising on the coronaries, very compromising on other things. So saline irrigations, prolonged procedure, and sometimes many topics of VT which happened because of the catheter movements. Some of them are very unstable. Blood loss and worsening renal failure all cause worsening heart failure. The question is about the devices. So we have ECMO, we have Impella, and we have IABP in our country. They are expensive devices. Let's see if a patient develops acute hemodynamic compromise, and then you resort to an ECMO, which is very common. Many people have ECMO standby. We have surgeons standby. If you get an ECMO after the hemodynamic compromise, you see the mortality is very high. 76% people died within 10 days of the procedure, and those who survived actually underwent an LVAD or a transplant. So you can see that if a patient develops acute hemodynamic compromise, it's going to be tough. So it is best to have a primary understanding of what you're going to do. And the pain SED score, which is beautifully done to look at patients who will develop a systolic blood pressure less than 80-90 or will require vasopressors or hemodynamic support is what is necessary to understand. Pulmonary disease, age more than 60 years, general anesthesia, ischemic cardiomyopathy, class 3 or 4, ejection fraction less than 25%, VT storm, diabetes. So it just takes a few minutes to actually calculate the score and tells you which track you have to go to. More than 15 should sound the bell. In this study, it is thought that substrate mapping and ablation can be safer for many of these patients. So in these patients who developed acute hemodynamic compromise, majority had substrate ablation. But if you look at the IVCCT registry with more than 2,000 patients, the early mortality and late mortality can be very well predicted by these scores. But one has to remember the 31-day mortality is not small. It's not a figure which can be ignored completely. So the value of substrate mapping and forgetting about too much of VT induction has been a very important concept. So there are many methods of doing it. We resort to these two methods which have been discussed today, but one of the good methods is substrate map using the ILAM mapping score that you look at late potentials, draw how they move, because just a lava or a late potential may not be the right target. So if you can identify the isthmus, like this has been an isthmus during sinus rhythm mapping, do a very limited VT induction, keep your HD grid catheter here in the isthmus, do a very limited VT induction, just mark that area, does it match that VT? And if it does, forget about the VT, just stop the VT and ablate this line. Is very useful method. And then looking at lava. So these are the two methods which are important. But does VT substrate ablation sinus rhythm mean no need for VT mapping? It's not true. Many people, 5% of the people have, you can say, a focal VT which may be arising just below the aortic cusp. Then you can have bundle branch re-entry in many of these patients, which you will miss. So it's always a good idea that you do good substrate map and then go for a limited VT induction. You don't need to go 3 extra stimulus, even 2 is good. You don't need to give isoprene to induce a VT. Now we come to another controversial subject. Is this preemptive mechanical support in high risk? So it was discussed, but there are a lot of questions. And question number 1, this is a pilot study. This is from Cleveland Clinic, and a pilot study did suggest that you can reduce the incidence of acute hemodynamic decompromise. But a recent study from the same group was presented as a late-breaking trial using a 5 or a 5.5 impeller. So this is the strongest and the best hemodynamic support that can be done. So you have to do it surgically. So the surgeons were involved. They put a graft in the axillary artery, put in 5 or 5.5 impeller, and then repaired the artery. Despite that, there was no difference in freedom from all-cause mortality, LVAD or a transplant in patients undergoing this treatment. 41 patients, and impeller or no impeller did not make. So there's a big controversy in this, that even if you have high pain SED score, whether you should do a impeller, adding so much cost and may not have a benefit, or just high pain SED score tells you that these are patients of no options. They should be, now you should be looking at a transplant or an LVAD already in these patients, and may say no to these patients also may be very important. Then there is a fluid overload situation which happens. So we have done some of the patients who had over oliguric before the procedure on CRRT, and it's very useful because if you keep your LA pressures within the range, getting them into cardiogenic shock is much lower chance. What happens is initially the LA pressure goes up, and then the systemic hypertension comes in, and then it is a vicious circle. So if you can have CRRT happening before the procedures in algouric patients, can be helpful. Okay, so let's look at the next problem. This is a patient who comes with a incessant VT to the lab, LV dysfunction, and this is the incessant VT, and multiple shocks had been received. We map it, and during mapping and ablation, he gets into this rhythm. So this rhythm is completely different from this rhythm, and now he's hypotensive, needing multiple shocks, and continuously getting into this rhythm. If we look closely at this rhythm, this is polymorphism which has set in. And if you look at lead 2, lead 3, there's a clear ST elevation. So lead 2, lead 3, AVF clearly showing UST variation, and you know there's a coronary issue. So from this ECG, monomorphic ECG, he gets into polymorphic VT with, now if you miss this ST elevation, you are in trouble because multiple shocks did not help him. And very soon we knew the problem and put in a catheter to look at the angiogram. I can't play it. It's not playing. And we realized that the PDA was blocked on the right coronary artery. Just putting in a wire and the thrombosuction catheter was all that was required to stabilize him. Then we continued and ablated this procedure, and he did very well. So if I conclude my talk, VT ablation is a high-risk procedure. So be fully prepared the day you have to do a VT ablation. Respect the vascular excess, because vascular complications can be life-threatening, and you will not be able to forgive yourself if the patient dies of a hematoma, or because they're going to get anticoagulants, and if a pseudoaneurysm. These are deadly complications and you don't like it. Study the aorta before you push in the catheter. Use a long sheet. Look at the calcium in the aorta. Just fluoro the aorta and see what is going on. Respect the coronaries. Sometimes one pushes the catheter too hard to get into the LV, and you may injure the left main, or you may be ablating near the coronary. Always respect the coronaries. As Dr. Narasimhan was saying, that when you go into the pulmonary cusp, you know where the left main is. Just think of all these things before you do. Monitor LA pressures if you have a transeptal procedure being done. Use risk scores before the procedure. Anesthesia team should be briefed what you're going to do and be in the room. Give importance to lactate, which should be done at least half an hourly or hourly, and ACT levels close to 350. This procedure is like AF ablation, so lower ACTs can be bad for the patient. Keep a track of the fluid and vasopressor. Sometimes the BP is down and the anesthetist pushes a bolus of vasopressor, which can be really bad. And keeping all these things in mind can really be helpful in taking care of the patient. Thank you very much.
Great talk, Dr. Balbir, because you have illustrated many practical points. Now, one thing, obviously, because of lack of paucity of time, you can make a comment in the answers, is perforation. Perforation is a very scary thing when you are especially doing substrate mapping for a long time. And scar, when we are mapping scar, we are not sure it's lack of contact or is it because it's a real scar. So you keep on trying and sometimes cause perforation. Now, impedance monitoring catheters that are in use these days. Now, has it helped you a lot in providing more safety and more confidence that you will not cause perforation?
So the commonest cause of perforations are using poor septal puncture techniques. So you could use an ICE or a TE. We use that most of the times. Or it could be a over contact. So if you have a contact force catheter, you're reasonably safe. And if you develop skills over a period of time, actually you can understand how much contact you're getting even with your feel, which even if you're not using a contact force catheter. So I've seen this contact business is the major cause of perforation if they happen. It is quite rare actually to get a perforation during a substrate map. It's not so common. And the third thing is that if you're doing a substrate map, use a multipolar catheter. The time spent is 1/3 or 1/4 of what would you do with an ablation catheter. The contact force with the HD grid, which we use, it may be same for the Carto system also, is very, very low. The catheter is so soft that you can get a good idea within 20 minutes or 30 minutes of the entire substrate. So your time spent with the ablation catheter, which is the highest risk for perforation, is much less.
All of them are great points. Anybody wants to ask any question? Yeah. No, the contact catheters, I think certainly they have helped a lot in increasing the safety, especially those people who are starting their VT ablations, the beginning of the learning curve, it's really very helpful. No further questions, I'll close this talk. Thank you, Dr. Barbir. We go on to the invited cases, 4 cases. Dr. Anis.
Thank you for the invitation. Because of lack of time, we'll straight away go to the case. This was a combination of 2 cases, almost similar, so I just included them in the slides. So ablation of polymorphic VT or VF in a clinical situation. So 2 patients, one was a 47-year-old male with recent admission with syncope and VT, severe LV dysfunction, also having non-ST elevation MI. He was seen in our ED with recurrent polymorphic VT or VF requiring multiple cardioversions. And after stabilization and angiogram, he underwent a CABG because he had severe triple vessel disease. The other one was a 64-year-old male with post-CABG with recurrent polymorphic VT or VF from the 3rd day after surgery, and he was having moderate LV dysfunction. In both cases, the VT was difficult to control with the medications. I mean, they could suppress the VT with the high-dose Xylocard, and in this situation, Xylocard was probably more effective in suppressing these VPCs which were causing the VT. But the problem was these patients, both were post-CABG also having different, multiple shocks, then they could not be weaned off the ventilator. One had tracheostomy done, and after 6 or 7 days also, I think he could not be weaned. He was on Xylocard. Moderate dose also was producing severe delirium. So this was the first case. Actually, his VT was seen before the surgery also, non-sustained VT, even on Xylocard infusion and Codron infusion. So these VTs were polymorphic, rapidly degenerating into VF, requiring cardioversion. So here you can see these VPCs, which are relatively narrow QRS VPCs arising from the LV side of the septum, most likely with posterior septum or inferior septum. This was the second case, again, polymorphic VT going to VF. You can see that the VPCs were, the VPC initiating the VT were narrow QRS complex VPCs, and the patient had an underlying AF also at this time. So he had multiple VTs. So our strategy in these cases is to suppress the VT-VF so that we can record the VPC morphology in isolation, and Xylocard was the best drug for that purpose. So in the second case of ours, this is the ECG, which is showing you could identify the 12-lead VPC morphology based on by getting these VPCs alone in 12-lead ECG. So strategy is in similar cases have been reported, I am sure, and there is publications. So basically, ablation for polymorphic VT depends on VPC localization, activation mapping for these VPCs, pace mapping, and ablation. And VPC burden and the risk of VF during procedure is always there, and that can be controlled or by titrated by adjusting the dose of or infusion of Xylocard. That's how we did both cases. So procedure was done under general anesthesia, and these patients needed small dose of noradrenaline to maintain their blood pressure because they were sick and also had severe LV dysfunction. When they were brought to the cath lab, they were only on Xylocard infusion. And the idea was that we can reduce and increase the Xylocard infusion and monitor the success rate of the procedure. So the first case, again, the VPCs were induced in the lab. So this, again, the VPCs going on to polymorphic VT can be seen here. So these localization-wise, the VPCs were localized to the mid septum or infroseptum, the posterior fascicular region. So ablating this, for ablation, because of the hemodynamic status of the patient, we did not have too much time for detailed mapping. So we went in with the ablation catheter directly. And the idea is to localize these fascicular-like potentials or Purkinje-like potentials preceding the QRS onset of the VPC by a significant amount of time. And that was the first landmark or first target. So here you can see these VPCs, preceded by these Purkinje complex firing from these Purkinje cells sharp signals. And then you can see the VT, ongoing VT with sometimes split potentials similar to isolated Purkinje potentials. And you could also pace map from the border zone of the scar, which was near these areas, and get a similar morphology like the VT morphology. Not the VPC morphology, but the VT morphology. Here you see the mapping during VT, short duration VT, which we could sustain. You can see possible Purkinje-like potentials in the mid-diastolic segment with these fragmented potentials preceding the QRS complex, something like the entry or exit area signals which you get in mapping during VT. Some interesting signals, like in this case, during RF ablation, you could induce the same morphology of VT during RF ablation. Here you can see these, the signal that VF or VT terminating with the complex, the local electrogram, followed by absence of the next QRS complex, indicating we are achieving something like a block between the Purkinje potentials or abnormal Purkinje-like potentials and the VT in this patient with ischemic VT. And here, subsequently, you have stimulation of the fascicular signals giving rise to the fascicular potentials, giving rise to the VPC morphology, exactly like the VPC morphology. So, from the posterior fascicular region. So, one is wider VT during RF ablation, the narrower fascicular complex both during RF ablation at one point, showing how these two signals, the fascicular potentials are linked to the VT. Here again, further scar modification was done, looking for late potentials because this patient had a large septal scar or a minimal moderate area of septal scar and also posterior wall scar. So, scar modification. Here you can see the sinus rhythm and VPC with multipolar mapping catheter. Subsequently, how the same area where you get the fascicular potentials also gives rise to the abnormal Purkinje-like potentials from the diseased tissue, giving rise to the clinical VPC. Finally, after ablation, we ensured also scar modification, and we did VT induction with 2 extra stimulus, no induction of VT. So in 3D mapping also you can tag these early potentials here in the septal region, just near the scar area. Actually, there were 3 points from where this local signal was much earlier than the QRS complex. So we have to probably tackle all these 3 areas because we are not sure from where it is coming, but be careful to avoid the distal left bundle and fascicular potentials. So the second case was similar. Again, these VPCs, you have to, in this case, we had to reduce the dose of Silacard to bring up the VPCs. And then once the ablation is done, the idea is that you can completely stop Silacard and make sure the VPCs are no more coming and there is no VT or VF. Again, the same morphology of ECG. Again, during mapping and ablation, you get the same Purkinje-like potentials preceding the VPC, which goes on to VF. During these cases, sustained polymorphic VT or VF with hemodynamic compromise requiring DC version is common, as expected. Again, mapping is limited to identifying, localizing the VPC and abolishing the VPC as the first step of the procedure. Here you can see the local signal from the 3D mapping system here, and the ablation catheter shows a very early Purkinje potential preceding the abnormal VPC. And the same like in the last case, Purkinje potential preceding the QRS complex of the PVC can be identified during the VT also. One more important point is to avoid risk of injury to the left bundle. Here you can see that it's a distal left bundle signal is mapped in the ablation catheter. And during pressure from the ablation catheter, patient can develop complete left bundle branch block as is seen in this slide. Complete LBVB can happen and that can worsen the LV dysfunction in the future if you ablate the left bundle. So we have to be careful. So this is from pressure from the proximal part of the catheter, complete LBVB which was reversed. So voltage map again showing large area of scar in the lower septum in the second case and the apical region. And 2 methods of mapping in this case. One is VPC localization with activation mapping and ablation, and also exit sites by pace map and late potential mapping for scar modification. So finally, Silacard infusion is stopped in both cases. Then electric VT induction is done again to make sure that we have completely eliminated the VPCs, giving rise to the VF. Both these patients were successfully ablated and weaned off ventilator. One had an ICD done, one is still waiting to get an ICD done. Thank you.
Very good cases. See, one word of good cases, one word of caution for arrhythmia specialists dealing with the post-CABG. Polymorphic VTs, this can be very challenging. Why I say word of caution is many times incomplete revascularization by the surgeon is the cause for it. A long QT in the sinus rhythm is a giveaway that there is an ongoing ischemia. So many times surgeons don't realize one of the things they are not grafted. Somehow the heart is very unforgiving. It's forgiving if you put them on medical management even with serious coronary artery disease, but I don't know. Once you do incomplete revascularization, it's very unforgiving. So patients have been saved with polymorphic VT by a prompt angiogram and a stenting of the ungrafted vessel. So that is also one of the important reasons, because arrhythmia specialists are prone to see the BPCs and go after them and ablate. So this is a word of caution for them.
Yeah, that's true. In the first case, the BPCs were coming even before CABG, and that persisted after CABG. In both cases, they did not have a repeat angiogram. The patient became stable after ablation. Luckily.
Yeah. Thank you very much, Anis. Yeah. Dr. Vijay Shekhar.
Good evening, respected seniors and delegates. So, through the probably next 10 minutes, I'll be discussing this case, and for want of time, I'll keep it as short as possible. So, the history starts with a 13-year-old male, no family history, no comorbids. A patient presents with recurrent palpitations. Every time the patient has a wide QRS tachycardia, and it is non-responsive to the antiarrhythmics, and patient requires shock every time to be reverted to the sinus rhythm. So this is during one of the tachycardia presentations. So the patient has a wide QRS tachy with a left bundle morphology, and clearly there is a late transition and a left superior axis. Now going whether it could be an SVT with an aberrancy or a VT, I mean that classical morphological criteria don't suggest a VT. There is a rapid downstroke, but on the rhythm strip there is some suggestion of a VA dissociation. But still there are more features suggesting that it could be a VT more likely. So the differentials that we had in mind when we approached this patient was probably it is a VT of RV origin, background of ARVC could be present, and or an atriovesicular tachycardia, or very rarely or uncommonly a bundle branch re-entry VT. So we tried to pick up some clues from the 12-lead ECG after cardioversion, and here we could see that there is some terminal slurring of the QRS in V1, and you can see the P waves are not very prominent in the sinus rhythm ECG. The PR is also slightly on the higher side, and there is an LAHB pattern. So we were pretty sure that this patient was having some kind of an RV cardiomyopathy. That was what was causing the problem. But the echo was normal, and surprisingly the cardiac MRI also turned out to be normal. And since this patient was having recurrent episodes every time requiring cardioversion, patient was taken up for an EPS RFA. So baseline intervals, there was a mild prolongation of the HV interval, and since we also had an atriovesicular tachy as a possibility, we wanted to just rule out with the basic maneuvers of looking for a VA conduction and increase change in the HV and pre-excitation, which were again not suggestive of so. And the tachycardia was very easily inducible even with the catheter manipulation. So the same wide complex tachycardia, the clinical tachycardia was induced, and the HV was negative, VA dissociation was very clear, so the diagnosis of VT was confirmed. So then we proceeded with high density mapping. So using a HD grid, we mapped extensively, and then close to the site of the moderator band, when we were mapping close to the moderator band, we could find really early signals with the Purkinje potential. So we did not have an ICE at the time because the procedure was done in a limited resource setting. And but 2D echocardiogram, I mean a transthoracic echocardiogram, shows that the catheter position is close on the septal aspect of the moderator band. So since we did not have an intracardiac echo, so the 3D, we did a post-processing image after the high-density mapping because the high suspicion was that it was from the moderator band and intracavity structure. So this point density exclusion post-processing was done, which showed the earliest site of activation to be on the septal aspect of the moderator band. So this is the activation sequence, again confirming that it is a very focal VT that is arising from the moderator band. This just to highlight the multimodality that we had used that was available to us. So the catheter position on the transthoracic echo, the electroanatomical mapping with the PDX processing, the catheter position as well as the Purkinje potential on the electrogram, all suggestive of probably a focal VT arising from the moderator band. So this is during ablation, and within few seconds of the radio frequency ablation, you can see that the VT terminated. But when it terminated, the post RF, there was a persistent right bundle branch pattern. And post procedure, the HV had not increased much, probably a mild increase from the baseline. And it persisted. We waited for some time on the table. There was no recurrence of the VT. The VT was non-inducible. RBB was persistent. So we called it probably a successful termination of the VT. So this is the pre and post procedure ECG. The patient is currently almost on 2 years follow-up. The RBB is still persistent, but without recurrence of the VT. So just a few aspects about the moderator band VT. We know this moderator band is structure that connects the septum as well as the RV anterior wall, and it houses the right side of the Purkinje system. So now there are increasing case reports and understanding about this moderator band being an important cause of idiopathic VF as well as ventricular tachycardia. So this review article elegantly describes the different proarrhythmic mechanisms of how moderator band could lead on to either a polymorphic, VT-VF or a monomorphic VT. And interestingly, there are some unique mechanisms that are attributable to the moderator band, just like in a Brugada because of the endo-AP gradient. Similarly, the moderator band has a moderator band RV gradient, which gives rise to a phase 2 re-entry, which is predominantly the cause for most of the arrhythmias. So not only does it results in a PVC triggered VF, but also monomorphic VTs is also possible, because the moderator can also behave as one of the limb of a macro reentrant circuit, and that can also result in a monomorphic VT. So this, I will not go into the details of other things. The paper beautifully describes the various aspects of proarrhythmic mechanisms. So all these arrhythmias have been documented from a moderator band. It could be just VPCs or it can be a monomorphic VT. And the clue from the ECG morphology is what our patient typically had: a left bundle branch, late axis, late transition, and a left superior axis. And so that is what is very classical ECG morphology to suggest it could be a moderator band VT. There have been multiple reports and case studies of how ablation has been successful in suppressing these moderator band related arrhythmias. And most of the time, the ablation, usually the strategy for moderator band arrhythmias is to target the Purkinje potential, which precedes the QRS. So it can be either at the septal insertion site or the free wall. And some of them have advocated a little more extensive ablation because there could be multiple exit sites along the moderator band. So ablation along the length of the moderator band is also being advised, because the moderator band by itself has a variable anatomy, and the length and the width of the moderator band is also variable in different patients. So a little more extensive ablation is being suggested rather than a focal ablation for such arrhythmias. So the challenges that we might have when we encounter a moderator band VT is not every time you might be lucky enough to find a Purkinje potential, and sometimes delivering energy can be difficult because of the fiber sheath that is present within the moderator band. And again, catheter stability and inability to maintain consistent contact, because it's a free floating structure, although it is attached to both ends, sometimes the anatomy can be a little variable. Hence, use of intracardiac ice contact force sensing catheters can improve the outcomes of such procedures. So I'll stop here and thank you for the opportunity.
Good case of moderator band VT. Any questions from the audience?
No, sir. Yes, sir. Yes, sir. So the thing is, even with the cardiac MRI being normal, we had planned a follow-up MRI. Probably it is a evolving ARVC which might later on present. So we have plans to do the MRI and genetic testing, but patient is on follow-up, but we have not done it yet. Yes, sir. Was normal.
So this is one of the differentials for exercise-induced VT also, no? I mean, exercise-induced VT,
yes,
the
sir.
moderator band VT.
Yes, sir. Yes, sir. But this patient did not have that typical exercise-induced history was not there. It was relatively, the patient would develop palpitations randomly. It was not always related to exertion.
Thank you, Dr.
Thank you,
Vijay.
The next presentation is an online presentation. Dr. Anindya Ghosh.
Good afternoon, everyone. At the outset, I would like to express my sincere thanks at having been given this opportunity to present a case in this prestigious forum. My case is about an unusual ventricular tachycardia which was ablated at an unconventional site. My name is Anindya Ghosh. So this case is about a 61-year-old male who is a known case of ischemic cardiomyopathy who has severe LV dysfunction with an ejection fraction of 25%. He presented to us with congestive heart failure symptoms and incessant palpitations for a week. He had previously incurred an inferior wall MI with a rupture of the basal ventricular septum, which was treated by a double vessel CABG with patch closure of the VSD. He then further underwent a percutaneous closure of the residual VSD patch defect with a percutaneous amplifier post-MI muscular VSD occluded device in 2021. That was for a refractory CHF symptoms despite guideline-rated medical therapy. For information, the size of the device was mentioned to be 20 millimeters. This is the tachycardia ECG of the patient. It shows a regular monomorphic white QRS tachycardia. There is an incomplete left bundle branch block morphology with a QRS duration of around 150 milliseconds. There is an intrinsic cord deflection which is more than 60 milliseconds, and there is late precaudal transition at V4. The mean frontal QRS axis is 20 degrees, and although AV dissociation cannot be ruled out because of the wandering baseline, the most important evidence is seen in the baseline ECG. It shows a full PR and right bundle branch block morphology, albeit with some post infarct changes, and then a QRS duration of 200 milliseconds. So a tachycardia narrower than a baseline ECG also is an indirect evidence for a ventricular tachycardia. So for this ventricular tachycardia, the patient was taken for an invasive electrophysiological procedure. The plan was to perform, and because it was an LBB tachycardia, the plan was to map both the sides of both ventricles during sinus rhythm and then during tachycardia, and attempt to enter in the tachycardia if possible. So this is a sinus rhythm bipolar endocardial voltage map of both the ventricles showing low voltage areas which were defined as less than 0.2 volts in the basal ventricular septum. This is the LAO view. The same map of the left ventricular endocardial aspect in the RAO view shows the same extent of the scar or low voltage areas in the basal inferior ventricular septum. So the tachycardia, which was clinically stable, was easily and reproducibly induced by atrial overdrive pacing. The tachycardia was mapped with an endocardial with multipolar HD-grid catheter. The peak intrinsic cord deflection V5 was taken as a fiducial reference, and the window settings were calibrated to cover 90% of the tachycardia cycle length. You can see here minus 23, 263 to plus 176 milliseconds. And the entire tachycardia cycle length could be accounted for with an early meets late pattern in the activation map seen here in orthogonal views. There is an early meets late phenomena suggestive for re-entry. Also, there is an isochronal color crowding in this basal midventricular septum. Within a narrow interval, there are at least 4 colors which signify a zone of slow conduction or decremental conduction. The signals and the electrograms at this site are magnified here, and they represent almost 70% of the tachycardia cycle length and harbor near field multi-component mid to late diastolic potentials. This was surprisingly over the VSD occluder device, as can be seen in orthogonal fluoroscopic images with the retrogradely placed SD grade catheter seen here over the device in both the views. There are additional catheters which are labeled here. So this is the proposed VT circuit. There is isochronal crowding in the basal midventricular septum, and they are surrounded by 2 functional line of blocks, which measures approximately 11 millimeters. Important thing to note that the device was 20 millimeters in diameter, as was mentioned in the first slide. So this is the biventricular endocardial voltage, endocardial activation map during the tachycardia, which shows passive activation of the right ventricle, and the entire cycle length of the VT could be accounted for in the left ventricular endocardial aspect. This is the fluoroscopy images showing the grid catheter over the device. Further, we performed an ventricular overdrive pacing to determine whether it was the site of an isthmus or nearby bystander. We can see the EGM to the QRS at the site is long, 240 milliseconds, which is half of the tachycardia cycle length. And we tried ventricular overdrive pacing, pacing at around 50 milliseconds faster than the tachycardia cycle length at 430 milliseconds. We can see the local potentials here, and which is captured at the 4th pacing beat, and immediately upon the capture of the local EGMs, there is entrainment of the VT with concealed fusion. The paced morphology of the paced morphology of the 4th pacing beat matches the tachycardia cycle length, matches the tachycardia morphology. So this is the VT beat, our clinical VT. This is the paced morphology of the 4th paced stimuli, although it is distorted by the pacing artifact because of the high pacing outputs which were needed to capture the myocardium at that site. Also, with the 6th pacing stimulus, there was VT termination without global capture. This entire maneuver, and just before termination, at the 4th and 5th pacing stimulus, the stim to QRS was also long, 240 milliseconds to be exact, which was same as the EGM to QRS. So this was interpreted as a concealed fusion with reset, and the extreme form of reset at that VT termination, which was seen at the 6th pacing stimuli. And this represents the pacing site to be in a protected isthmus. So with that, the ablation catheter with contact force ablation catheter was taken at the same site over the VSD occluder device, and after delivering radio frequency energy at the set settings, which will be seen in the next slide, the tachycardia could be cleanly terminated. Also, we can see several variably timed high frequency, high amplitude electrograms on the ablation catheter, which likely represent the catheter contact with the metallic VSD occluder device and during various phases of the cardiac cycle. And this can be taken as an indirect mechanistic evidence that the site of successful ablation was indeed as shown in the fluoroscopy images, that is over the VSD septal occluder device. These are the set of lesions which were delivered. These are the total number of lesions. Site of such the RF lesion which resulted in successful termination, which is the 8th lesion, and the temperature and power settings and the irrigation settings. So we know that scar VT ablation involves critical isthmuses and involves pacing maneuvers, The important thing is implantable prosthetic devices have been previously shown to cover these sites of potential isthmus, especially like the Melody valve in RVOT for RVOT stenting in TOF. Once they cover once they are implanted, they cover the sites of the RVOT scars, and it becomes impossible to ablate those sites. In our case, this was a central report of a protected isthmus being present over an implantable endothelialized ventricular septal occluder device. Now, regarding endothelialization of occluder devices, it typically takes 6 months to 2 years for ASD devices, but the data is not known for VSD occluder devices. And it is classically believed that the new endothelialized tissue is typically devoid of myocardial cells and is essentially a non-conducting scar, but there have been histopathological reports showing the presence of myofibroblast cell populations over those new endothelialized tissues. And we also know that this myofibroblast cell population is also a component of ventricular scars implicated in scar VTs. So if we combine this with a slowly conducting, surviving myocytes in the vicinity, they form a conducive environment for a potential isthmus. So with this, I'll stop my presentation and I'm open for questions.
It's a good case. I mean, I think it's the first reported case. I mean, congratulations, Dr. Anindya. I was going to ask about how the myofibroblasts are, whether it is documented or whether it's just endothelial intimal proliferation over the tissue, over the neo device which is there. So still, any other questions? Narasimhan sir, you want to comment on? Yeah, it's a good case.
These not only devices, there have been situations where aneurysm has been repaired with a patch and VT was arising from the aneurysm. So these challenges often happen. Now, any special precautions you took with a Implanter device in the VSD, closing VSD, while mapping the ventricles?
Anindya, you want to answer that question, or Dr. Ullas would like to? I think he's offline. He's offline.
See if you can make a comment.
I think everybody noticed that it used to give the metallic artifacts whenever you go nearer to that place. So that was the greatest of the challenge. And in and around the place, I'm not very sure that that was exactly on the VST closure device. Maybe the adjoining areas could also been a part of the isthmus. So it's not necessary. It caused a scar around it. I do not think we should be able to prove that the isthmus was actually on the surface on the left ventricular side. It could be a scar because of the VST device closure.
Thank you. The last case of the day, Dr. Darshan.
Thank you. At the outset, I'd like to thank the entire AIG team for having me here. So after all the stress of handling VTs, I think we'll go back to some PVCs and try to finish the day with that. Disclaimer, this case is very similar to what Dr. Sachin presented earlier, but with a change in the way we handled it right at the end. So it was a 20-year-old male who presented to us with frequent palpitations from 2 months prior to presentation. Very symptomatic in that he was troubled by the post-PVC forceful beat that he was having. His ECG showed frequent PVCs, we'll just get to that in a minute. And his echo also showed an EF of around 40%, although he did not have any symptoms from the reduction in his ejection fraction. This was his baseline ECG. This was again taken from the lab, but his ECG was very similar to this, happening in a trigeminal or a quadrigeminal pattern at most times. A closer view of the ECG, you can see it was an outflow tract PVC with 2-3 AVF being upright, a QS in AVL and AVR, with the Qs being greater in AVL than AVR, and you also have transition that's happening between V3 and V4. His Holter showed a burden of around 28%, no real VT seen, and he had fairly uniform PVCs without any diurnal variations as such. He was put on metoprolol 50 milligram, did not respond to it, so we decided to take him up for an ablation given his younger age. Fairly significant slur that we can see in the initial portion of the QRS. His MDI was 0.72 and his pseudo delta was around 50 milliseconds, again going in favor of epicardial origin of these PVCs. So as protocol, we first start mapping within the venous system, first going into the GCV and the AIV, and for us in this case we were fortunate that he had a fairly good sized AIV. We were able to advance our ablation catheter all the way in. This was a 3D map of an activation map during the PVCs. We were able to bracket within the CS. Again, the near field signals here representing local activation were all at the onset of QRS, but if we look closely at the signal, we can see that the signal there starts off with a small far field, followed by the near field. Now, if we annotate to that far field, we have the onset actually preceding the QRS, or this signal actually preceding the QRS. But if we annotate to the near field there, which represented the local potential close to where the GCV was, it was right at the onset of the QRS. So we decided to proceed with further mapping. We went into the RV, obtained a map, activation map of the RV outflow tract. Again, fairly late signals occurring right at the onset of the QRS, nothing really beating the QRS here too. We then went into the aorta. The right sinus was late. We went into the left aortic sinus, which was the earliest site within the aorta. Again, here you have a small signal. You really don't have a pre-potential seen here or a really brisk signal seen here that we sometimes see with these outflow tract PVCs or VTs, especially coming from the summit area. Now, I've annotated here just to have a comparison with what we saw with the CS. So even with annotation to the onset of the local EGM we see, we are only around 80-85 milliseconds early. So with this, with mapping of 3 different structures with the ventricles being considerably late, we decided to first try an ablation within the GCV because the far field signal there was considerably earlier compared to all other sites. So ablation in this GCV actually led to suppression of PVCs after a period of around 15-20 seconds, but would only come back again after 2 to 3 minutes of wait time. So we tried a couple of lesions there, that didn't work, so we went out back to the aorta, we did another lesion here, again ablating. PVCs would suppress after around 20-25 seconds, would come back after a period of 3 to 4 minutes. So we decided to look at all other vantage points available to access the LV summit. So one such structure is the pulmonary artery just above the pulmonary valves, as Dr. Sachin alluded to earlier. Again, mapping there was fairly late, much later than actually even what we found in the RV outflow tract. We then decided to explore another structure which is very rarely accessed for any ventricular arrhythmias, which was the left atrial appendage. So as we can see here, the left atrial appendage actually drapes the LV summit. And you have your vascular structures underneath the left atrial appendage, both the bifurcation of the left main as well as your GCV turning around into the AIV. So we decided to go in and map the left atrial appendage. Mapping for far field ventricular electrograms, keeping in mind that here you're going to have your atrial signals being really large amplitude and only having far field Vs. So when we look at the EGMs here, you look at the first 3 beats, which are sinus beats, you have a large A signal and you have small far field Vs. Now when you look at this ventricular EGM during the PVC, you can see that it is fairly early. And it fairly matches up with what we saw when we were mapping within the GCV. This was around 93 or 95 milliseconds early and the other was around 98 milliseconds early. So more or less being at the same site from 2 different structures, we thought, okay, we didn't have much lasting success, at least with ablation from the GCV. So why not attempt an ablation from here? But before doing that, and because of the proximity to the vascular structures here, we wanted to do an angiogram to see how close we were to This is just the three maps, the left atrial appendage, the aorta, and the CS maps put together with earliest site within the CS. Again, remember the CS map here is with annotation to the far field rather than the near field signal there. So this was an angiogram with the ablation catheter in the left atrial appendage at the earliest site there. You can see how close it is to the LAD, and within 5 millimeters on multiple cines that we took. So we decided not to proceed with an ablation here. So the next step available for us was to again reaccess the venous system and try to look for any branches. So we decided to do a venogram first of the distal CS. There is some balloon-induced dissection of the tip of with the tip of the balloon, but there we can see a branch. It's just a faint flow. You can see it again on the LA view. Again, it's not a very steep LAO, but you can see the AIV coming down. At the same time, you see a branch that's going more laterally, again going back to where your LV summit would be, which is what was described as the retropulmonary branch that is seen in this area. So we decided to wire this branch. So we used a over-the-wire balloon with a hydrophilic wire, advanced the wire into this branch, and this was the EGM obtained from the wire with the balloon over it. You can see a small A and a big V during the sinus beat. You can see the atrial EGM there again. Subsequently, you have a ventricular EGM that starts off. You can see a very fractionated sort of EGM during unipole. Again, the timing of this, if you annotate to the onset of the EGM here, and it's really difficult to annotate this EGM with the way it is. So if you just annotate to the onset, you can see that it is fairly within the same ballpark as what we got from the left atrial appendage and also from the distal great cardiac vein. So one, we decided to do what Dr. Sachin wanted to do, inject some alcohol in. So we had some of our lab techs running around to source some alcohol. This was towards the end of the day. Now, we decided to do something else in the meantime, and this is something I got from Venkat. This was a couple of weeks after APHRS, where he was describing a case, similar case he did, where he decided to ablate with the wire. So what we did here was we advanced the balloon further in a little. It was impossible to actually advance it right into the branch simply because the branch was narrower and the balloon shaft is not that flexible to take the curve. Tried to cover as much of the wire as possible. Immerse the wire or the exposed part of the wire into an underwater drain as such. And then we used the ablation catheter to ablate with the tip of the wire. So this is what we had. We ablated with wattage of 30 watts, and within 3 seconds there was complete suppression of all PVCs. And we continued our ablation for around 45 seconds. We repeated an ablation again for another 45 seconds. Subsequently, there were no PVCs at all. This was his Holter a month after procedure, no PVCs, patient doing well, and his EF had recovered back to normal. So an in-depth knowledge of anatomy is indispensable in modern day EP, whether you're doing an AF, whether you're doing VT or PVCs, and especially so when you have a lot of structures that are surrounding each other, because in a lot of cases you may need different vantage points to try and access inaccessible or so-called inaccessible sites. A systematic approach is important, even for cases which may appear very easy and straightforward. Sometimes, maybe towards the end of the day, we look at a narrow complex tachycardia, we say, okay, this is AVNRT, V on A, going forward to ablate it, or something that looks like a simple outflow tract PVC. But it's important to be meticulous and be stepwise to ensure that you're successful at the end of the day. Novel techniques are useful, but they are not a substitute for conventional techniques. Use them only when all else fails. Conventional techniques are still what is going to save your day every time. So these techniques may work sometimes, may not, but to be used only as a supplement to what needs to be done regularly. Thank you.
Thank you. Again, an excellent case. Dr. Darshan, just for me to learn, can you show the image where the wire is in LAO view? I mean,
the LAO view I wasn't able to put up. We didn't actually store the LAO view. So the REO is what I have.
It was like going towards the septum inside,
yes,
right?
so
in LAO view?
It's not going into the septum. So the wire, so if you look at the angiogram, let me try to see if I can.
So which vein in that previous view?
One second, let me just play that. I'm not able to freeze it, but if you look at angiogram here, just pay attention to this part here. You can, on the LA view, you can see the AIV coursing down. At the same time, you see another branch that is going laterally.
Yeah, that's
right next to it. That is the branch that was cannulated.
Going laterally.
Going laterally.
Okay. In LA.
Yeah, in the LAO, you can see it right next to.
Okay, okay.
You can see the AIV coming down, and yeah, right next to it there. You can see this branch here.
Oh, okay.
You can see it on the REO also. It's
Yeah, sure.
Please use mic.
See, if you concentrate on V1, okay, because the rest of the mapping has the V1, okay, let's make that as a template.
okay. Can you put up the screen, the slide, please?
Yeah, so let's memorize this. It has a tiny little R, okay, and you know the transition's way out. But let's memorize only the V1. Then we'll go on. Go the ECGs only. See here the morphology. Go next. See here. Go next. See here. Yeah.
Yeah.
So I think it's very important that what actually your mapping has to have the same template. Ultimately, you got it written off, but I thought that should also be mentioned. Correct? And then I think it is the effect of the cumulative lesions. Ultimately, you needed a little bit of a touch somewhere, and that is where at the left atrial appendage. What was that power, etc.? Power, etc. you use at the.
Well,
the CS.
I really advise strongly against doing a PVC ablation from the left atrial appendage. You know, that left atrial appendage actually protects your left main. I think that is why the God has made that. So
precisely, sir. So there's been a couple of case reports of an ablation being done, but safety is always first, and that's why an angiogram was taken prior.
And because we should not be ablating there, we should not be mapping there. You know, if you are going to be using your catheters, and you said at the end of the day, you are more aggressive, and you could lead to perforation. So the lesson here is, well, that's a vantage point. Anatomical knowledge is okay, but that's not at all a safe region to play around.
Sorry, sir? 30 watts and with the wire, yes. No, sir. So the balloon that you place over the wire, you don't inflate the balloon to allow for flow to happen. When you inflate the balloon, you're going to have impedance that rises.
Curious, when you connect the ablation catheter, you need the saline because?
I think you'll have a lot of problems with impedance when you expose it to air. You'll have better transmission of energy from the ablation catheter to the wire when you do it underwater.
there are no more questions, yeah.
Did you do a coronary angiogram with the wire in situ to see if the coronary is near the wire?
We had done it with the CS, with the ablation catheter in the distal GCV. We didn't repeat it with when we were doing it with the wire.
Okay. Map the coronary artery. I'm just asking that did they do an angiogram to be sure that the wire is away from the coronary, so that when they are ablating inside the CS with the wire, we are not harming the coronary?
Raghav and Vilas, it's a fantastic case. I think we'll have it's probably 9:30, and every good nice thing has to come to an end. Thank you, wonderful case. All of you, give him a big hand. And couple of housekeeping announcements. Tomorrow morning we'll assemble here at 8:30 for breakfast, and then we'll start with the dissection, which will be done from the animal lab, and it will be telecast here. So all of you can assemble here. There are vehicles at the hotel for transport, but if there's any problem, please get in touch with Dr. Daljit. So, and Muttaya, of course.